conference so that we get good things, we get solution and the strategies for the benefit and the health of the EXA region. We glorify you in your name, in Jesus Christ. Amen.
Thank you so much, Madam Vice President, for giving us this word of prayer. Let me also take this opportunity, ladies and gentlemen, to recognize the presence of the Minister of Health from Uganda, who is with us here. Madam, yesterday we heard that you are on your way coming to Malawi, and we are very grateful that indeed you are here this morning. May I take this opportunity to give you 2 or 3 minutes, Madam, to greet the 74th Ministers' Conference. Greetings from Uganda and anything that you would want the conference to hear. Over to you, Madam.
Thank you so much, the Honorable Ministers of Health, Director General of ACH, colleagues, ladies and gentlemen, good morning. I only knew that it's only in politics where there is just hijacking somebody without preparation. But being an expert in that area, I can say 1 or 2 minutes. My name is Honorable Banifa Bangerana Kawoya. I'm the State Minister of General Duties in the Ugandan government. I bring greetings from our President and the people of Uganda. I am happy for the hospitality. I am happy that I had a standing in Under Secretary in the name of a PS. I have been briefed that Uganda, he did so well where I'm not in. But now that I'm here, he has handed to me officially. Now I am able to continue. I only have one message to all of us. Everything that is within the Ministry of Health or the health sector, nobody is going to get solution other than ourselves. And I was telling one of my colleagues that some people think I'm radical. I am not. But with what is happening, that some donor countries are cutting off their aids, that is another good direction that we must wake up and do something as Africans. The expertise is ours, the medicinal plants are ours, the knowledge we have, so we better start. Finally, I want to thank everybody within this conference that have made it a reality. And again, I always want to say, when COVID came in, most people countries were not prepared. Now that was another signal to make us prepared, and it was a unifying factor. Now we are unified, and we know we are going to get solutions together. No one in the Ministry of Health or in health sector can walk it alone. We can only walk together. You walk alone, you won't reach where you are going. We work together, we shall accomplish our vision. I thank you so much.
Thank you very much, Madam Minister, for those remarks. We have always known that every time you are always ready, Madam, to give us a speech. That's why we took this opportunity to allow you to welcome us as well and give us brief remarks. Today, we are on day 2, and our first session this morning is combating neglected tropical diseases in the EXA region. And our moderator for session 5 as well as session 6 is Zimbabwe. May I request Zimbabwe to take it up. Thank you.
Thank you, Director of Ceremonies. Good morning, Honorable Ministers, HMC Chair, ladies and gentlemen. I would want to start by apologizing for yesterday. I was very hopeful that my minister was going to arrive, but I confirm that he can't make it anymore. So I'm Dr. Dodzo. I'll be chairing the 2 sessions on behalf of the Minister of Health and Child Care, Dr. Douglas Mombechura, for Zimbabwe. I'll be chairing plenary session 5, combating neglected tropical diseases in the EXA region. And Honorable Ministers, HMC Chair, allow me to ride on the already observed protocols. I'll start by giving a short overview on the neglected tropical diseases. Neglected tropical diseases remain a significant public health challenge in the EXA region, mostly affecting the most vulnerable populations. So this plenary, honorable ministers, ladies and gentlemen, the session will actually explore strategies, success stories, collaborative efforts aimed at combating NTDs. And special emphasis will be placed on lessons learned from Malawi's journey towards eliminating of trachoma, contributions by member states, and global perspectives on ending NTDs. So this session will provide a platform for sharing knowledge, identifying the challenges that we are facing, fostering partnerships to accelerate progress in eliminating NTDs. We have objectives to meet during this session. So the objectives are to highlight Malawi's success in trachoma elimination as a model for addressing other NTDs in the region, and also to provide an opportunity for member states to share their progress, challenges, and innovative approaches in combating NTDs, and also to present insights from global initiatives such as Uniting to End NTDs to align regional efforts with global strategies. So it will also foster dialogue and collaboration among stakeholders to accelerate NTD elimination in our EXA region. So now coming to the presentations or the session topics, we are going to start by an opening statement by the Honorable Minister of Health, Malawi, who is going to talk about lessons learned along the path towards the disease elimination, the case of trachoma elimination in Malawi. Then thereafter we'll jump to a presentation by the Uniting to End NTDs. Then we'll come back to statements by the different countries. So at this moment, I would want to humbly ask the Honorable Minister of Health, Malawi, to make a statement. Over to you, Malawi.
Good morning, Madzuka Bwanji. Tadzuka. On behalf of my Minister, Honorable Kumbidze Kandodo Chiponda MP, I'm honored today to provide a statement on behalf of Malawi. The Honorable Ministers of Health that are present in here, the HMC Chair, the Director General EXA. It is an honor to share Malawi's journey in eliminating trachoma as a public health problem, a milestone which was validated by WHO in September 2022. Trachoma still remains a leading cause of preventable blindness across the southern part of Malawi, Africa, and it has been endemic in Malawi since the 1980s. And the path to elimination has been challenging, but at the same time rewarding. So what are the key lessons that we learned as a country? First of all, we had a comprehensive strategy implementation, the Safe strategy, which was adopted from WHO. The abbreviation S stands for surgery, A for antibiotics, F for facial cleanliness, and E, environmental improvement. This strategy was pivotal in eliminating of trachoma, as it has a holistic approach in addressing all facets of trachoma transmission. That was number one. Number two, we had strong partnerships and stakeholder engagement with international organizations, non-governmental organizations, as well as local communities, which then we ensured mobilization of resources and also community ownership. For instance, the International Trachoma Initiative's donation of azithromycin was crucial in this aspect. Number three, we also had community involvement and behavioral change by one, intensifying in health education. What we did was to integrate trachoma-related messages into national school health curricula, as well as sanitation guidelines, which then enhanced community awareness and also promoted preventive behaviors. The other strategy was robust monitoring and surveillance systems. This helped us to have data-driven decisions, whereby we conducted baseline surveys and continuous monitoring, and that allowed us to have targeted interventions, and also at the same time to have a timely response to the disease prevalence. The approach of monitoring and surveillance was essential in tracking progress and at the same time identifying areas needing urgent attention. We also made long-term commitments in terms of having long-term planning, recognizing that the disease elimination is a long-term endeavor, and Malawi maintained consistent efforts over more than a decade, and this was demonstrated by the resilient health systems as well as commitment to public health. Despite all the achievements and all the strategies, we still encountered some challenges. Number one, there was resource constraints. We had limited financial capacity as well as human resource to such a level that in some areas it was difficult to deliver the services in combating trachoma. This therefore underscores the need for sustained funding and as well as capacity building. At the same time, we also had behavioral barriers. That is, despite increased awareness, translating knowledge into sustainable behavioral change required continuous engagement and innovative communication strategies. In conclusion, therefore, honorable ministers and the chair of this session, Malawi's experience underscores the importance of a comprehensive, community-driven approach, robust partnerships, and unwavering commitment to eliminating of neglected tropical diseases. We therefore encourage other nations to learn from our journey, adapt strategies to their context, and also collaborate towards a trachoma-free world. We extend our heartfelt thanks to all our partners, communities, and stakeholders who contributed to this achievement. Thank you, Chair.
Thank you, Malawi. I'll ask members to keep their questions and comments for the plenary session. Now I'll call upon the next presentation. For those who just joined, I proposed that we start with the presentations, we get into discussion, then we end up with the statements from the member states. So I'll call upon the next presenter. It's a presentation by Uniting to End NTDs.
Honorable Ministers, distinguished ladies and gentlemen, good morning.
Good morning.
Thank you, that's a fantastic audience. Yes, I know Mauritius is here. My name is Okwe Alabi Undeyi, and I represent an organization called Uniting to Combat Neglected Tropical Diseases. And our sole aim is to mobilize resources to end NTDs. I'll come to how we do that in a minute. I'm not here alone. I'm here with our amiable chair of the board in person of Dr. Winnie Mpanju Shimbushu. A round of applause for Dr. Winnie, please. Dr. Winnie, I guess some of us would know, was a former Director General for XIHC, and she was equally a retired WHO Assistant Director General at the headquarters in Geneva, where she led the cluster on WHO's global programs on HIV/AIDS, tuberculosis, malaria, NTDs, and related global partnerships, including the Global Fund. It's a pleasure to have Dr. Winnie on our board. I also am here with another colleague, Ruth Rensberg. She is a Senior Resource Mobilization Advisor. Here, over there is Ruth. I'm sure some of us can remember Ruth very well. Okay, let's dive into it. I'm testing my tech knowledge here. Excuse me, doesn't seem to work. We will go the old-fashioned way. So, next slide, please. Like I said earlier, Uniting is okay. It's going to be an interesting one. Uniting is a global advocacy organization, and our sole aim is to mobilize resources to end neglected tropical diseases, and we do that in support of the WHO roadmap on neglected tropical diseases and in support of the Sustainable Development Goal, particularly SDG 3.3. We work with partners across the globe, and we have a unique communications platform to give a platform for partners globally to advocate for neglected tropical diseases. We use our power to convene partners, like I said earlier, and we facilitate communications. And we mobilize resources from donors, from multilaterals, from government, from all sort of donors to achieve this roadmap goals and targets. And as mentioned earlier by Honorable Chair, she's given us a bit of context on what NTDs are. NTDs are preventable, they are treatable. They affect the poorest of the poorest, the very vulnerable in our society, people with limited access to quality health care, people with limited access to wash, people without whom we cannot achieve the universal health coverage. And that is the sole aim of Uniting, trying to push as much as possible to mobilize resources so we can make the cycle of poverty end with these people. Next slide, please. So, we've had a brief intro about Malawi eliminating trachoma, and that tells us that progress is happening. We have an ambitious roadmap target that says we want 100 countries to have eliminated at least one NTD by 2030. We've had that fantastic example from Malawi this morning. And I just want to take us through, the next slide please, some of the progress that we've recorded in recent times. We have an amazing 55 countries to have eliminated at least one NTD. Isn't that amazing? And out of these 55, you will begin to know that 23 are African countries, among which we have 3 in the EXA region. This is a great progress to celebrate. Also, in the NTD roadmap, we have 2 diseases earmarked for eradication, which guinea worm disease is one of them. And we are getting nearer to it. In 2024, there were only 13 human cases of guinea worm that was reported. We have 690 million fewer people requiring interventions for NTDs in 2023 compared to 2010. And we have the amazing support of the pharmaceutical industry partners who continue to donate medications needed to end the plight of the vulnerable, needed to end the suffering that NTDs cause in our society. We have 30 billion donated between 2011 and 2024, and we still have commitment of 28 billion tablets towards the 2030 roadmap. Next slide, please. So, what does this tell us? It tells us that progress is possible. It's possible in our lifetime to have a world that is free from NTDs. However, there are barriers. We still have quite a number of them. Next slide, please. There are still, and I'll start with the big elephant in the room, the same one we've all been talking about. It's no longer business as usual with the donors. And who knows what it will be going forward. But as far as we know now, there is a reduced funding from the donors. And the priorities for the donor is changing. It's becoming we first and maybe others. It's changing. That's the reality we have found ourselves in. UK government caught £4 billion towards NTDs in 2022, bringing an end to the Ascent program. And we've seen the USAID stop order. We are all aware of what is happening. This continues to impede progress. This continues to stall the move towards achieving the 2030 roadmap targets. I will just leave the rest because I'm sure we're following them so as to move on. We have change in political landscape. I mean, I can't overemphasize that, resulting in such a policy like the stop order. We cannot quantify the devastating effect this will have. And most importantly, That initial slide we saw with the 55 countries that have eliminated at least one entity, we do not want a rollback on that success. We don't want it. And that is a potential that would happen as a result of these barriers. Next slide, please. What can we do then? Yes, we have talked about these barriers. What can we do? I would like to say this old saying that we're all used to. We say when there is a will, there is, oh, are we here? When there is a will, thank you very much. When there is a will, there is a way. It's probably not requiring something that comes from the space or out of this world. It's more about what we choose to do. And I'll go back to the interesting statement from Honorable Minister of Health in Uganda. She said, nobody will get solutions other than ourselves. So we have a role to play. We have a commitment to end these diseases that keeps people trapped in poverty. And there is a huge benefit to ending these diseases, economic benefit to ending these diseases. Mainstream entity program services within established national health system. There are established systems already. How can we mainstream entities within these existing systems to bring about the change that we desire? How can we strengthen our health systems so we can achieve disease elimination? And the truth is, strengthening health system is one of the critical components for effectively controlling NTDs. And it's not just going to control only NTDs, I'm sure we all know. It will give us a benefit across board, different diseases. We're talking about disease elimination. Addressing NTDs will contribute to broader health system improvement. If we address NTDs through strengthening our health systems, we will achieve a strengthened health system that will appeal to a broader improvement. It's a win-win situation in any case. Investing in NTDs offers significant health and economic benefit. For instance, in 2023, Deloitte carried out a research on Nigeria, which shows that Nigeria could gain a potential 19 billion US dollars in increased productivity by meeting the 2030 elimination goals. So, it's a win-win. It's in any case a win-win. When these people are free from entities, they will become economically productive, and that would feed back into the society, into the economy. Next slide, please. We know that quite a number of us, countries, have endorsed the Kigali Declaration. The Kigali Declaration is a high-level declaration on NTDs, which was launched by His Excellency President Kagame in Uganda during the Kigali Summit. Quite a number of countries have endorsed the Kigali Declaration. We want to employ countries that haven't. I have a long list there: Botswana, Ethiopia, Ghana, Djibouti, different countries. About 11 of those countries are from Africa already. I want to encourage those that haven't. You can still do it. You can talk to my colleagues and after our presentation to say more about that. Next slide, please. So we can sustain progress and celebrate more eliminations because, remember, it's a win-win situation. And when there is a will, there is a way. It's a win-win situation. And to sustain, what can we do? We need adequate funding. And some of the ways we think we can unlock funding in an innovative way, these are just a few we have here. World Bank International Development Association. The IDA offers loans at very minimal rate with a very long-term repayment terms. Flexible, very, very friendly terms. We want to encourage ministers of health. Liaise with the ministers of finance. IDA 21 Circle applications will soon be put together. You can work with your ministers of finance to ensure that entities are included in this application under disease elimination. Also, Global Fund. The Global Fund is known to support interventions that address root causes of diseases. And there are several ways we can include entities in our Global Fund applications. We encourage member states, work with partners like Uniting, work with partners at country level to ensure that entities are included in Global Fund applications. We can do this under training and healthcare. We can do this for community-based surveillance, developing integrated delivery platforms alongside other essential health services. We can also create entity-related interventions under strengthening drug distribution networks. All of these areas are good ways entities can be embedded into the Global Fund application. African Development Bank is another fantastic opportunity. You will be shocked that they have funding for entities that probably has not been utilized. Uniting is working with other NEPAD and AFDB, and we're collaborating on 6 country projects to showcase that regional public goods, such as economic growth, through the control of entities and elimination of entities is possible. We encourage countries that fall within that region to apply. You can find out more from us in the course of the conference. And next slide, please, which is my final slide. We need concerted action and sustainable financing if we want to meet the SDG goals. We have 5 years to go. 2030 is just around. We want to safeguard the AD1 elimination wins. 55 countries, just a bit after the midpoint. We don't want to roll it back. We need very strong political commitment and will. We need country ownership. We need an increased, sustained domestic resource allocation to entities. And we need to explore innovative ways. We have a few publications that we can share even on this. We call on every member state of EXA to prioritize entities. Let's put our money where our mouth is. I hope I put that in the right order. It shows everyone is listening. I'll call my colleague, Ruth Brensburg, to take us through this very interesting half a second.
Good morning. Are we awake? Yes. Are we awake? Yes. Right. When I say end, you say NTDs. End. NTDs. What? End. NTDs. What? End. NTDs. Eliminate NTDs. Eliminate NTDs. How? Guys, come now. We're in Africa, we have funding problems, and this is one area where we've had incredible progress, and we have the opportunity to demonstrate that progress in each of your countries. You can show to donors that disease elimination is possible. When I say eliminate, you say NTDs. Eliminate? NTDs. Right, here we go. You all know that I can dance very well, maybe not like the national troupe, But now here's our song, and we want you to remember today, when we unite, when we act, we can eliminate NTDs in our lifetime. Yeah? Okay, now we're just waiting for it to work. Technology doesn't like NTDs today. 1 minute. Yeah. Make sure you send your statements. We just give it a second. I have 4 children. They are all adults, teenagers, who live in a TikTok culture, right? Everybody does, social media. So we decided, let's put NTDs into the mainstream. Let's put NTDs into a space that even young people can understand. So we encourage you to get up, to dance with us, and eliminate NTDs. Yeah. Good things come to those who wait, eh? My mom always used to say. You know, things always work when you don't want them to. Yeah, Miguel. Okay, seems like maybe not. Okay. I don't think it's working. Okay. Okay.
It looks like technology is failing you. I may end up asking you to sing and dance.
Well, I don't know about my singing voice, but I'm well versed in lots of different gospel hymns. You can make a request. But perhaps what we can do is share the presentation and share the link out to the member states.
Perfect.
And we really are excited to be talking to each of you about the opportunity to engage with the African Development Bank as an example. We are working on that proposal this year. And if your country falls into the regions where we plan to work, we could support you to apply to the bank for support, which is something that Uniting is working on at the moment. But today we encourage you to incorporate NTDs in your national line items and to work with us to eliminate NTDs today. Thank you.
Thank you very much, and thank you for the presenters. Malawi and Uniting to End NTDs. I'm also looking at time and would want to move fast and make sure we go by time. From the 2 presentations, from a statement by Malawi, in summary, I would say they've shared their strategies for eliminating NTDs with focus on trachoma. And the strategies include strong partnerships and community engagement, community awareness, robust monitoring and surveillance system. And they've also highlighted their challenges, mainly resource constraints, especially inadequate funding, which is pointing for the need for sustained funding. And coming to Uniting to End NTDs, they've shared that their mandate is mobilizing resources to end NTDs, and that is in support of World Health Organization's NTD roadmap and SDGs. And they emphasized that progress is possible and we can come to end NTDs. And they also repeated what the Honorable Minister said: nobody can get solutions for us other than ourselves. However, we need to act together as a team and fund NTD so that we are able to eliminate them. Ladies and gentlemen, at this juncture, I would want to invite you for comments, questions. Comments, questions? It looks like members have really understood the highlights from the two presentations, and I don't see any hand for comments or questions, which is good for me as the chair in terms of time management. Yes, so now I would want to move on to the next step, which is statements from the member countries. And just to remind you that the statements should be short, 3 minutes each. Thank you. I want to recognize Kenya.
Thank you very much, Chair. All protocols are observed. So, Kenya continues to bear a significant burden of NTDs and other tropical vector-borne diseases. And to address this, the country is implementing its third National Master Plan for NTD elimination, that is 2023-2027, which is fully aligned with the global and regional roadmaps. The master plan outlines a structured approach to NTD interventions, targeting the elimination of 4 endemic NTDs by 2028, namely human African trypanosomiasis. We have onchocerciasis, also known as river blindness, lymphatic filariasis, and trachoma. Kenya has made notable progress in eliminating endemic NTDs. Kenya was certified guinea worm free in 2018, and human African trypanosomiasis elimination efforts are advancing, with a dossier submitted for WHO validation and positively reviewed in April 2024. Onchocerciasis reconnaissance surveys and formative studies have been conducted with expert evaluations planned before extensive entomological and epidemiological assessments. Lymphatic filariasis, all the 23 endemic implementation units in Kenya have actually successfully completed mass drug administration, rounds and past transmission assessment, placing Kenya on the track for lymphatic filariasis free validation by 2028. On trachoma, only about 5 endemic areas remain under treatment, with cross-border collaborations ongoing to address hotspots and persistent areas. Kenya is also strengthening the control of other entities, including leishmaniasis, through enhanced diagnosis, treatment, and vector control strategies. Schistosomiasis and soil-transmitted helminths. Kenya is the first African country to upscale precision marking with 89% coverage, and that is 42 out of 47 counties that have been mapped, and the pediatric parasequential rollout underway. Skin NTDs and snakebite envenoming. Kenya is piloting the WHO Skin NTDs app and conducting integrated mapping of snakebite venoming. So to ensure robust monitoring and evaluation, Kenya is committed to conducting baseline and endpoint surveys to track elimination progress, establish a comprehensive NTD data repository including updated endemicity maps, but also strengthening cross-border collaborations to mitigate transition risks. We would like to acknowledge the WHO and the AU roadmap for NTD elimination, and we endorse the recommended actions to accelerate programmatic impact and cross-cutting interventions. And as a country, we seek excess technical support in advocacy, resource mobilization, and capacity building to sustain these efforts. So we endorse the implementation of the NTD roadmap and reaffirm our commitment to achieving the set targets, ultimately reducing the burden and threat of neglected tropical diseases. And in conclusion, Kenya is advocating for one, increased budgetary allocation at national and subnational levels, adequate staffing, and integration of NTD's programs into health systems, but also strengthen cross-border coordination to sustain elimination gains. And lastly, scaling up complementary interventions, including WASH, vector control, and behavior change communication. Thank you, Chair.
Thank you. I want to recognize Mauritius next, and strictly 3 minutes. I'll be beating my glass to show that it's time up. Over to you, Mauritius.
Thank you, Madam Chair. You won't need to do that. So, all protocol observed. As usual, I'm going to ask certain questions before I start my statement. Why is it called neglected tropical disease? Why did we neglect it? Is it because there's lack of knowledge? Is it because of lack of resources? Or perhaps lack of commitment from different angles, not only government, we are talking of all stakeholders. And finally, lack of seriousness. So when I talk about neglected, why is it neglected? Because we chose to neglect it. It should not have been. If we really understood why it is a tropical disease. Why we neglect it, I don't know. But I suppose we should take a commitment from day one. As from today, it will be not neglected. We'll call that tropical disease, not neglected one. Not neglected at all. We'll say committed. So we all know that NTDs are a global challenge affecting 1 billion people. It primarily impacts marginalized population. We are talking of low income, subtropical region. It has complex epidemiology linked to environmental condition. The economic burden is very simple. It impacts our health system and national economics. There is some direct cost which is associated, like detection, treatment, care, and ultimately loss of human lives. There are indirect costs, loss of productivities, man hours, and other family problems which arise. NTDs in Mauritius, we face risk due to vectors. Disease of concern to us is dengue, chikungunya, rabies, scabies, etc. We do have an integrated surveillance in place. This is only possible when we collaborate with other ministries. I don't know whether I should say, I'm happy to say that there is no active case of dengue, chikungunya, rabies, etc. But they are waiting to attack and come to our shores. There has been sporadic cases of scabies. Our public health surveillance system is quite okay, I would say. There is active surveillance by Public Health and Food Safety Inspectorate. All passengers are monitored without fail at the airport and seaports. We have isolation, disease confirmation, fever surveys, vector control, etc. And one thing that we do all passenger which comes from risk countries are 100% checked by our health officers. Within 3 days, you reach your home, you get a phone call, you get a visit. You can't hide it. So we make sure it happens. There is a rapid detection response, as I say, in early detection and response. We have a list of notifiable diseases which ensures reporting. Our Public Health Act ensures it mandates disease reporting. Our dengue cases in Mauritius is about 6,851. Last case was in September 2024. We do have a strong laboratory capacity. We do have home visit because we understand when people are sick, they don't want to go to hospital. We do have dengue control measures like vector control, larviciding, fogging, etc. And this is done religiously as and when required and even on request. There's a lot of public awareness through risk communication and community engagement. There is always a campaign going on in radio, TV, and as they say, TikTok. Chikungunya in Mauritius, there was a major outbreak in 2005, 2006, I would say 20 years ago. It was controlled through detection, treatment, etc. We had, unfortunately, only 2 cases of imported cases, not local. Then there is lymphatic filariasis. We do have screening of migrant workers. We make sure that treatment are available. In 2020, there was only 196 cases. Now, in the last year, there was 623. Rabies in Mauritius, 5 years, no case. There is acute and effective surveillance at the airport. There is rigorous monitoring so that we prevent rabies. We also have to deal with scabies in Mauritius. You will see that in 2020 there was 1,581, now there is 1,400. I'm finishing, ma'am. How do we deal with that? Is because we do have school level screening. In conclusion, we are maintaining our surveillance. We do collaborate strongly with everybody, and the key word is continuous surveillance, continued. Thank you, ma'am. And I didn't extend too much. Thank you.
Yeah, thank you, Mauritius. I'll quickly move to Zambia. Over to you, Zambia.
Thank you. Thank you so much, Chairperson. Distinguished guests, let me say all protocols are observed. I bring to you warm greetings. I'll give these remarks on behalf of the Minister of Health. Neglected tropical diseases prevail in the tropical and subtropical region in at least 149 countries and affect more than 1 billion people worldwide. In Zambia, more than 13 million people at risk of being affected by neglected tropical diseases. Mother than children, most at risk are some children discontinue learning at school to take care of their parents who are disabled by NTDs, such as trachoma and elephantiasis. This often results in little or no education for these children, a situation that perpetuates the cycle of poverty in these families. Zambia has prioritized 16 entities categorized as follows. Those targeted for elimination, where we should interrupt the chain of transmission, and those that have no longer public health importance, and the third one, those which have targeted for control. The Ministry of Health has made significant progress in the fight against NTDs through various interventions with support from various cooperating partners. Our work has been on elephantiasis, schistosomiasis, and also the soil-transmitted helminths. We have conducted 5 rounds of mass drug administration since 2015, and we continue to conduct impact assessments to see the effect and also the impact of the interventions we are doing as a country. So far, we have made the following achievements. We have developed the Zambia national entities for 2022 to 2026, and we have also piloted MDA for pork tapeworm. We have conducted successive trainings for various health workers to ensure that they are equipped with the interventions on how we should handle the NTDs. And Zambia successfully eliminated trachoma in 22 districts out of the 56 districts which were targeted and also endemic for trachoma. We have some of the focus which we need to move from now onwards. We'll continue conducting trachoma impact surveys and also mass drug administrations, and also map the prevalence of liver blindness and also tapeworm. And we'll continue to strengthen surveillance for elephantiasis to ensure our goal of elimination of this condition by 2030 is not derailed. We'll support strengthening of the WASH program, as it is a well-known fact that most of the effective strategies for elimination of NTDs is the provision of safe water and sanitation to our communities. We initiate vector control for Bioasia in close consultation with the line ministries so that we have interventions which are in line with the acceptable standards at the international level. Thank you so much.
Thank you, Zambia. Thank you. I'll move on to Eswatini. Over to you.
Thank you, Chair, and good morning. According to the World Health Organization roadmap for neglected tropical diseases for the period 2021 to 2030, a significant milestone is the integration of all NTDs into a cohesive unit under the Ministry of Health. Eswatini takes pride in having successfully achieved this integration, resulting in substantial benefits that have led to remarkable progress and achievements in public health. Another critical milestone is the prioritization of the senior NTD program leader, who now reports directly to top-level management. This structural change has facilitated better oversight and accountability, contributing to the previously mentioned successes and positive outcomes in managing NTDs. The third milestone focuses on the integration of soil-transmitted helminths into antenatal care and immunization programs. Eswatini has once again successfully implemented this strategy, as evidenced by the availability of the anti-parasitic medication within both ANC and immunization services, thereby enhancing the health of mothers and infants. In collaboration with the WHO, the Ministry of Health has developed a comprehensive master plan that serves as a strategic framework. The NTD Master Plan for 2023-2027 is designed to govern the prevention, control, and, where possible, the elimination of neglected tropical diseases. This plan aligns with the broader NTD roadmap titled Ending the Neglect to Attain the Sustainable Development Goals, a roadmap for neglected tropical diseases 2021-2030. The primary objective of this master plan is to provide a structured tool for planning all relevant NTD programs within Eswatini. It aims to foster cooperation and coordination among various partners and stakeholders, promoting joint efforts to support the acceleration of progress towards the prevention, control, and elimination of NTDs. Specific NTDs have been identified as targets for elimination and control within the country. Notably, leprosy has been singled out as the sole disease earmarked for complete elimination. Other diseases like rabies, trachoma have been recognized for their potential to be eliminated as public health threats given their unique transmission dynamics. Lastly, the Ministry of Health is committed to its mission of eliminating and preventing diseases, injuries, and traumatic experiences among the citizens of Eswatini. To achieve this, the Ministry collaborates with an array of partners, including multinational organizations, United Nations agencies, and various non-governmental organizations. This collaborative approach enhances the effectiveness of interventions and broadens the impact of public health intervention initiatives in the country. I thank you.
Thank you, Eswatini. I want to recognize Tanzania.
Madam Chair, allow me to invite Professor Janabi to speak the statement from Tanzania.
Madam Chairperson, Honorable Ministers, Head of Delegates, esteemed guests, colleagues, good morning.
Good morning.
Jambo,
Jambo,
and Muli Bwanji.
Tirimino.
The United Republic of Tanzania commends the 74th EXA Health Ministers Conference for its collective efforts towards achieving the goals of combating neglected tropical diseases in the region. Madam Chair, I really join Mauritius about this name, neglected tropical diseases, and really we should consider several other names in future, maybe tropical equity disease, priority tropical diseases, endemic, which will shift from the geographical position where we are, or preventable tropical diseases. Neglected tropical diseases comes with a stigma. We should consider in future. But otherwise, neglected tropical diseases are a diverse group of communicable diseases that prevail in tropic and subtropic, as we know. They are caused by several pathogens, ranging from viruses, bacteria, parasites, fungi, and toxins. NTDs primarily affect impoverished communities and are responsible for significant health, social, and economic consequences. Some commons which we see in our region are lymphatic filariasis, trachoma, schistosomiasis, onchocerciasis, which is a river blindness, and Chagas disease. The WHO recognized NTDs as a major public health concern. WHO Action Plan, the NTDs Roadmap for 2021-2030, aims to control, prevent, eliminate, and eradicate these diseases through integrated approaches. This includes preventable chemotherapy, individual case management, vector control, veterinary public health, water, sanitation, and hygiene WASH initiatives. Tanzania remains committed to these goals. As a result, we have reduced the number of individuals requiring chemotherapy by 76%, equating approximately to, if you round up, it's about 40 million fewer people compared to 2021. Our goal is to achieve a 90% reduction by 2030. This remarkable progress includes 96% reduction in lymphatic filariasis, with 114 out of 119 endemic districts halting mass drug administration, MDA, and a 90% reduction in trachoma, with 62 out of 69 endemic districts ceasing the MDA administration. Further, the government of Tanzania has made a substantial stride in domestic financing for NTDs, with a fourfold increase in the national funding for NTDs intervention, from US dollars 818,837 in 2021-2022 to $6.9 million in 2023-2024. This achievement was made possible through integration of NTDs interventions into the comprehensive council health plans, a key strategy for ensuring financing sustainability at the local level. The government of Tanzania has also made an unprecedented commitment in financing the salaries of health personnel from national to subnational levels and covering indirect costs for drugs, transportation, strengthening health systems to deliver NTDs services. Our efforts to integrate NTDs intervention in Tanzania health sector have yielded notable success. NTD services, including diagnosis and treatment, and now are fully integrated in our national health system, with a primary health care at the forefront. NTDs health commodities for both case management, mass drug administration, and are integrated into the Ministry of Health routine supply chain management system. Additionally, NTD's data is now part of the health management information system, improving data accessibility through district health information system, and increasing the visibility and traceability of NTD's commodities throughout the electronic supply chain system. The government of Tanzania believes that achieving success in combating NTDs is inseparable from improving resource mobilization, integrating NTDs interventions into primary health care and national health information system. This shift from a disease-specific focus to integration within existing platforms is crucial to ensuring sustainability of our efforts. President Samia Suluhu Hassan has played a pivotal role in addressing neglected tropical diseases in Tanzania and beyond. Her leadership and commitment have widely been recognized. I'll mention a few. A political will and commitment. President Samia has shown a strong political will in tackling NTDs, making Tanzania a role model in combating these diseases. Her involvement has been crucial in mobilizing resources and fostering collaboration. It was presented here in the Kigali Declaration. President Samia emphasized the importance of involving affected communities in policymaking. This approach has been instrumental in ensuring that interventions are community-centered and effective. And 3, global partnership. President Samia is actively engaged in global initiatives such as Reaching the Last Mile Forum, where she pledged Tanzania's commitment to eliminating NTDs. This has helped secure significant funding and support from international partnership. Those are few to mention the contribution of the President, and when there is a political will led by the head of the state, changes can be achieved. Thank you for your attention. Merci beaucoup. Asante sana. Sikimo kwa mbele.
Thank you, Tanzania. I will move on to Uganda. Over to you, Honorable.
Thank you so much, Chairperson. Allow me to stand on protocol set. I want to join the Honorable Minister and the Minister of Tanzania that we should seriously think of the way it is named neglected tropical diseases. Chairperson, as I've been listening, I have heard statements from my colleagues mentioning about the milestones they have reached, the achievements. That means that there is nowhere that there is neglected tropical diseases. The achievements, we may not have achieved our targets, but we are moving. So the word neglected, in my remarks, I will not refer to it. I'm going to refer to the progress of Uganda as far as managing tropical diseases, with your permission, Madam Chair. The tropical diseases are public health care issues. And once all our member states are managing public health care issues, these tropical diseases are also there. Maybe we have not moved to that, but at least as we go on, I'm sure we shall meet our targets. As far as Uganda is concerned, we have a high burden of tropical diseases, 18 in number, that affect mainly the rural poor and result in reduced socio-economic productivity, as we have already heard, affecting the development of the population, meaning affecting our economy. If we want our economies to accelerate, then we must focus so much to ensure how do we deal with these tropical diseases. The country was certified from guinea worm free in 2009, and since then no reports of indigenous cases have been posted. That means that we are on the right track, but as you know, Uganda is bordering many countries and hosts many refugees. There are still scattered cases, especially from South Sudan, and we are still working on it. Progress is going on. Number 2, Uganda was certified for elimination of sleeping sickness. That is a credit, therefore not negligency, as a public health problem. The Rhodesian type is a public health problem. Uganda with high fertility rates, we are working on it. All 74 lymphatic infanticide endemic streaks have been declared free. Mass drug treatment is going on, and a dossier for those that are still experiencing the damage. Out of the 49, 52 formerly trachoma endemic districts have interrupted trachoma transmission. We are having only 5 where mass drug administration is still being conducted once in a year. Athromax for adults and tetracycline for children. More than 1,000 people have undergone trachoma surgery, regained their sight, though we still have a big number, 4,000 people who remain behind, but surgery is continuing. River blindness also has been our issue as a country, transmitted by black flies, was an endemic in 48 districts. So far 44 are free. We are having 4, which again Uganda is having mass drug administration, and we are going on with the volunteers. Our strategy for vector control is working. Bilharzia remains the only public health problem. Tropical disease, 96 districts out of 146, still a big number, but all this also is varying in the MISTI, which we are working on as a country. Leprosy is another area where it continues to affect our people. Much of the time and much of the money is spent on TB, but leprosy also is now on board. For example, in 2022-23, out of 489, 307 in 24, they have showed positivity, and as of now, we have a very strong team of surveillance and ensuring strengthening our health care using what we are calling now in Uganda as community workers health care program that goes to the villages. What is Uganda's call for African action? Of course, number 1, we shall think about naming neglected tropical diseases to tropical diseases only, or progressive to managing tropical diseases. Number 2, we need a political will, as it has been said. Everything to move on, there must be a political will. In member countries, you all agree with me, the health sector is the one which gets the least budget. So we need to push for having a big budget for our public health care, for example, and to see how the tropical diseases can be integrated to other health care services. Budgeting, knowledge sharing is the best way. As you are all aware, Uganda has gone through a lot of pandemics, from Ebola to COVID, but we are now a case study in managing all these pandemics. At the same time, I want to assure you together that we can manage these tropical diseases you are referring to as neglected. So they are neglected by who? Maybe ourselves, but we should address it. I thank you so much, and I am here to listen and share much from you. Thank you.
Thank you, Uganda. Lesotho.
Thank you, Chair. Honorable ministers, distinguished guests, ladies and gentlemen, there are certain diseases that have been ignored for far too long, with daunting effects on those they afflict. These neglected tropical diseases, though predominantly found in tropical areas, also occur in other parts of the world disproportionately, affecting poor communities. In 2010, the Kingdom of Lesotho conducted a situation analysis which confirmed non-endemicity of trichoma, schistosomiasis, lymphatic filariasis, and onchocerciasis. In 2015, a mapping survey also identified soil-transmitted helminthiasis as endemic with about 47.6% national prevalence, while schistosomiasis was found to be non-endemic. Through the developed NTD Master Plan in 2018-2020, Lesotho managed to implement a mass drug administration for soil transmitted helminthiasis to reduce morbidity and transmission that was there. Recently, Lesotho also has finalized a 2025-2030 neglected tropical diseases master plan with the focus of addressing both preventable chemotherapy NTDs and also case management NTDs like leprosy, snake bites, scaries, and rabies. Despite these efforts, challenges such as limited resources, navigating of our difficult terrain, arising pandemics like COVID-19 remain a concern in the management and elimination of NTDs. Thank you for your attention.
Thank you, Lesotho. I kindly ask for 5 minutes injury time for me to present the Zimbabwe statement. I'll present the Zimbabwe Progress Report on Tropical Disease Control and Elimination. Zimbabwe is committed to the control and elimination of tropical diseases by year 2030. The main tropical disease endemics in Zimbabwe are schistosomiasis, intestinal worms, lymphatic filariasis, blinding trachoma. We also still have a challenge of malaria. Additionally, Zimbabwe is also endemic to rabies, anthrax, human African trypanosomiasis, that is sleeping sickness, and also scabies. Baseline mapping for schistosomiasis and STH was done in 2010 into 2011, where 47 out of 63 districts were found to be endemic for bilharzia and 46 endemic for intestinal worms. As a result, Zimbabwe started to implement mass drug administration for these priority tropical diseases from 2012 to date. We appreciate the medicine donation that has been coming through World Health Organization. The 8 years of mass treatments in Zimbabwe have seen the reduction of bilharzia and intestinal worms burden among preschool age children and school age children, thereby improving on their learning ability. The results of 2018 impact assessment results showed that the 6 years of successive MDAs reduced the schistosomiasis prevalence from 22.7% to 5.1%, and that of intestinal worms from 7.2% to 0.7% preference among school-age children. The confirmatory mapping on lymphatic filariasis in 2020 also showed the disease being eliminated from 39 districts in 2015 to only 7 districts which will need mass treatments. Trachoma mapping was conducted in 5 phases from 2014, 15, 19, 23, and 2024, leading to mapping all 63 districts in the country. Currently, we are conducting impact and surveillance surveys, and we are on transition as regards trachoma surgeries. We intend to submit part of our trachoma elimination dossier in 2025 and achieve trachoma elimination by 2027. Zimbabwe targets to eliminate all tropical diseases by 2030, and we are committed to the tropical disease declarations, especially the Kigali Declaration and others. There is a national tropical disease task force committee and steering committee. The national NTD task force is responsible for NTD control program design, monitoring progress, and evaluating the NTD program, supervising the national survey activities, production of the national survey report, and drafting of the national NTD policy. The steering committee is a core group of technical personnel that play an advisory role, including planning NTD control strategies. The national task force oversees implementation of activities at national and sub-national levels. Members of the steering committee are from Ministry of Health departments, WASH, Ministry of Primary and Secondary Education, ministries responsible for agriculture, water, and information. The academia, partners, and donors also form part of these committees. We are also working towards eliminating malaria together with support from World Health Organization in all the EXA countries and SADC 16 countries. We are working with various partners in NTDs, including technical support from World Health Organization, Higher Life Foundation, Deworming Innovation Fund, which supports MDAs for schools, and also we have our new NTD Master Plan 23 to 27, that is activities which are fully budgeted to eliminate NTDs as a public health problem, and the total budget for 2023 to 2027 is amounting to $82 million US. Thank you. So thank you, honorable ministers, distinguished ladies and gentlemen. We have come to the end of the first session, and we want to move to the second session. I'll allow 5 minutes to breathe and sip some water. Thank you. Do you have one? Yes. Yes, you. I will allow him. Do you want to give it? Can do one. Yes. Okay, I will give you the floor. So whilst we are sipping some water, there's somebody who has volunteered to give an energizer. Over to you. Over to you, sir.
Chair, may I have a word while we are in recess?
Sorry.
I suppose so that since everyone is here, we should adopt that we neglect the neglected term. It should be removed. We should propose to our ministers that we should no longer call it neglected tropical disease. Thank you.
Thank you. I hear you loud and clear. Thank you. There's no mic.
Where's the energizer now?
Where's the mic? You can go there.
No, yeah, the energizer. Okay. Right, yeah. Okay, fine. Yeah. Yeah, but then I'll do it. Right, thank you very much, Chairperson. May I ask the audience to rise? Please be on your feet.
Okay. We are dancing.
No, we are not dancing, but we just want to use some terms that we use in non-communicable diseases. Probably you have heard of, so we are from the non-communicable diseases. When somebody has diabetes, the sugar level sometimes they're high or they're low. So the terms that we use, when it's high, we call it hyperglycemia. When it is low, it is hypoglycemia. So I want us, when I say hyperglycemia, I just want you to jump, because the hyper is up, isn't it? When it's hypo, it's what? So let's see who will grab these terms. Right, the exercise begins. Hyper, hypo. Thank you very much.
Hello, can we continue? Can we continue? Thank you very much for the energizer. As if you know that I'm diabetic, so if I happen to get into hyper, make sure you jump high. When I get into hypo, which is most unlikely because of the food that is here, you also go down. Thank you very much. Now we want to move on to the next session, which is plenary session 6. Investing in health workforce in the EXA health community region. And as an overview, the health workforce is a critical pillar for achieving universal health coverage and sustainable development goals. This plenary session will focus on strategies for investing in the health workforce within the EXA health community region it will also explore progress made in addressing human resource challenges, implications of health labor market analysis, and advancements in scaling up innovative learning models such as the collegiate model of learning. The session also aims to foster dialogue, share best practices, and identify actionable steps to strengthen the health workforce in the EXA region. We have objectives that we are supposed to meet during this session, which are to highlight progress made by EXA health community member states in addressing the human resources for health crisis, to present findings from health labor market analysis and discuss their implications for implementing the African Charter on Health Workforce Investment, and also to review the progress and challenges associated with scaling up the collegiate model of learning in the EXA region, and lastly, facilitate dialogue on opportunities for enhanced investment in health workforce development. So we have presentations for this session. The first is an opening statement by the Honorable Minister of Health, Zambia, reporting on progress made in addressing the human resources for health crisis in Zambia. Over to you, sir.
Thank you, Madam Chair. My name is Panj Kaunda. I'm the High Commissioner from Zambia to Malawi. I'm here on behalf of Honorable Elijah Mchima, MP, who is our Minister of Health. He sends these apologies. He had to stay home because there's an outbreak of serious health on all the borders, so he had to go there and look at the issues. Progress made in addressing the human resources for health crisis in Zambia. Your Excellencies, ladies and gentlemen, human resource for health is one of the essential requirements for the effective health service delivery. The overall goal for Zambia is to have an adequate, equipped, well-distributed, and motivated health workforce. The government of the Republic of Zambia has been implementing various strategies to strengthen the human resource for health in the country, as outlined in the National Health Strategic Plan of 2022 to 2026. One of the critical strategies outlined in our National Health Strategic Plan is the progressive recruitment of health workers. Towards this, the period 2022-2024, Zambia has recruited an additional 18,305 health workers, bringing the total of funded posts in the Ministry of Health to 82,059 health workers from 3,754 for the current population of 20 million Zambians. However, this is against an overall establishment of 151,394 approved posts in the ministry, giving us a funded rate of 54%. The major concentrate in this area has been the tight physical space the country has been experiencing following the debt distress. This was made worse by economic effects of the COVID-19 pandemic, and most recently, the devastating drought in the country has experienced. Following successful efforts to restructure Zambia's debt, the country is on the path to economic recovery. And within the expected improvement in the physical situation, more health workers will be recruited. Your Excellencies, ladies and gentlemen, on the training output side, the country has seen a marked improvement in the output of trained health workers across the major cadres in 2024. The stock of health workers on the market exceeds 108,000 workers for the first time in the country's history. The country has a significant number of workers working as volunteers, including medical doctors, a situation that requires urgent solutions. Especially noting that the fact that the country still has a huge deficit to meet the population of demand. Health workers' retention is one of the important activities being implemented by the government to keep our most experienced staff in the service. In order to enhance staff retention, the ministry has been providing both monetary and non-monetary activity incentives to health workers. Some of these measures include: 1, using decentralized approach. The ministry has been recruiting health workers with a preference to local residents. This ensures that deployed staff suffer less inconveniences with settling in a new environment. 2, in addition, using the Constituency Fund, Development Fund, at local level, rural facilities are being improved by providing the required social amenities such as housing and school infrastructure. The ministry has in addition been providing monetary incentives such as payment of a rural or remote hardship allowance on a monthly basis through the payroll. This is in addition to other allowances that all health workers are entitled to. 4, the ministry has further provides opportunities for training and development as well as career advancement through promotions. And last, the ministry, but not least, the ministry has trained polyvalent community workers who are being contracted to support the last mile delivery of primary care and health services. In addition to the recruitment and retention of health workers, Zambia has also been making efforts to improve the diversity of skill and competences of the workforce. To this end, the ministry introduced the Specialist Training Program, SDP, with the aim to train an additional 700 specialist doctors by 2026. So far, 278 medical doctors have been trained in various specialized fields, with another 306 currently in training. The program is aimed at addressing the geographical inequality of the distribution of specialists. Excellencies, ladies and gentlemen, may I take this opportunity to appreciate the East Central and Southern Africa health community for its capacity building initiatives for which our health workers have benefited immensely. For example, over 136 specialist surgeons have been conferred with the fellowship in different surgical specialists through COSESCA. These specialists, apart from providing service, also work as trainers in the local specialist trainings. In addition, Zambia appreciates the various capacity building programs for peri-operative nurses, anesthesiologists, gynecologists, and other essential health workers. This has resulted in an improved patient outcomes. Your Excellencies, ladies and gentlemen, as I conclude, allow me to reiterate that regardless of challenges in the country is facing, investment in human resource for all health is a priority. And the government, under the leadership of His Excellency Mr. Kande Chilema, the President of Zambia, will continue to implement measures that are impactful to attain the desired results in both short-term and long-term. I therefore urge member states to continue making significant investments in the health workforce and indeed support the efforts and initiatives of a CASA healthy community in investing in our health workers. I thank you.
Thank you, Zambia, for the opening statement. Now we are moving on to the presentations. Unfortunately, for the first presentation, World Health Organization, Afro, is not here to present. So we jump to the second presentation, which is Progress Report on Scaling Up the Collegiate Model of Learning, Challenges and Opportunities from EXA College of Health Sciences, and presented by my own professor from Zimbabwe, Professor Christopher Samkange. Over to you, sir.
If I may be allowed to adjust this a bit. Good morning, Madam Chair. All protocols observed. All protocols observed. May I ask our colleagues who are doing the slides to try and keep up? No, it's easier if you keep up with me. I shall be saying next slide, and you then move on to the next slide. I am very happy to be here and very proud to be here representing the colleges of all disciplines. My name is Samkange. I am from COSEXA and I'm a past president of COSEXA. And as a result, I shall be using examples from COSEXA to illustrate some of the points that I would like to make. But that doesn't mean that the other colleges are not contributing and have not contributed much. I'm representing the Senate of the College of Health Sciences based in Arusha, and which is the coordinating body that brings us all together. Next slide. These are the colleges that you have as a community, and there are 11 of them at the moment. The oldest college is actually the College of Nurses, EXA-CON. Next slide. The college will only have value if they are actually impacting the healthcare delivery system. EXA Health Community is recognized within the region because it's competing with WHO, competing with SADC, competing with COMESA, which all have health divisions, and also the African Union itself. And each one of us has had to find a niche. You remember way back in 1994, we had a meeting of health ministers in Victoria Falls. And the major topic was the review of saying what is the relevance and what is the mandate of the health community. The health community is unique in that it is run, owned, and belongs entirely to the health ministers. Within SADC, within AU, within COMESA, the health ministers are part of a bigger picture. But this is an organization that is entirely driven by you, honorable ministers. You own it, and where it goes is entirely dependent on you. And the findings in 1994 was that the greatest strength, which has therefore been the mandate of this organization, has been the human resources for health. Training, education, and performance is actually your niche. And it would be very good if, after this session is done, we re-energize ourselves to focus on that which is important and that which is productive and that which has an impact. I've shown on you there what the colleges have done since inception, and our first graduate in COSEXA was in 2004, and there were 4 of them, and we have now graduated a total of in 2024, a total of 1,048 surgeons. When we started, our target, at that time when we had only 400 surgeons in the entire region, was to try and say in 25 years, we should have added 4,000 surgeons. At that time, we had medical schools which were producing M.Med graduates, but most of them had a capacity of 4. The biggest in Nairobi at 8. And when you do the maths, you actually realize that we're never going to catch up. But since we started with the collegiate training system, we've actually realized that we can meet the target, and we are on course to meet the target. The anesthetists joined us, and over the last 3 years, they've actually added 41 anesthesiologists to the troop. And I'm sure when the others start graduating their students, the impact will be amazing. Next slide. Where did we come from? In 1990, the nurses formed the first college, and they were driven by a need to recognize 2 things. One was to produce quality nurses, standardized operations of nurses across the entire region. But they also recognized that the system as then designed would not produce the right numbers. There will be some countries which do not have a strong enough system to produce the kind of quality product that was needed across the region. So the idea was to use strengths within the region, institutions within the region, to strengthen the weak amongst us. And indeed, when COSEXA came online in 1999, we recognized the same issue. If I may use our host nation as an example, when we started in 2004, they had 5 surgeons. Malawi now has 41 surgeons. And some of them are in specialties that did not exist in this country at that time. But by using the strengths of surrounding countries, by using the strengths of our partners in South Africa and West Africa, we've been able to actually produce specialties and subspecialties to cover the actual needs of our communities. Whilst we were bringing these organizations and creating the colleges, the health ministers looked at it and said, what do we actually need as a region? When we formed COSEXA, it was arising from the Association of Surgeons of East Africa, ASEA. And at that time, we wanted to form a college called COSESA, the Colleges of Surgeons of East and Southern Africa. But the ministers passed a resolution saying we need to have EXA in the name so that we recognize that it belongs to the community. And that is why you see all our colleges now have got EXA in the name. Secondly, we also now recognize that these bodies must not act autonomously only, but must be coordinated and mutually supportive. And the College of Health Sciences, based in Arusha, was created to provide this coordination, to provide this ability to standardize, but also to inject direction, uniformity, and collaboration. Next slide. What is the collegiate model? The collegiate model really exists as a means to provide ability to perform at the highest level. It's an educational approach which is emphasizing collaboration, but the greatest strength of our colleges is that they are community-based. We derive our priorities from what the individual communities that we serve actually require. When the priorities amongst the communities are in one direction, we need to be responsive enough to react to that. And as a result, you find that the colleges are relevant, the practitioners that graduate from them are relevant, the services that are produced are also relevant and poignantly apt. And it is this which makes the usefulness of the colleges inescapable. We need autonomous institutions which operate as a part of a large network and collaborate with one another. And the strength of the collegiate model therefore becomes academic rigor. We ensure that the high quality standards in education, as much as it is in health care shop floor performance. There is an interdependence so that affiliated institutions share resources, share curricula, and best practices. One of the things that we've learned over the few years that COSEXA has been in existence is that at any one time, one of our countries will come up with a solution to a problem that others are having. And we share it each time we meet in our annual AGM and scientific conference so that we all are uplifted at the same time. It creates a unified framework which creates consistency across institutions, both in teaching and in learning. And one of the biggest emphasis that we make in the colleges is not so much on the teaching. I can stand here and preach to you, but you don't have to hear anything I say. But it's what you hear that carries the benefit. And it's the learning that the students actually undertake that we value rather than our process of talking to them. Next slide. The collegiate model is best applied at postgraduate level. It's best applied in professional training programs so that you have institutions that share ideals, share objectives, and share teaching methods, but are able to actually develop an all-rounded individual. And we find that health sciences, medicine in particular, and law lend themselves to this. What you want to see are uniform standards so that you are promoting a consistent educational experiences across the affiliated colleges. And the key features become standardized curricula, shared accreditation, and common evaluation criteria. I'd like to say a few words about accreditation. The emphasis in all our colleges is that they are colleges without walls. What all of you will have noticed in your countries is that with the presence of all the 11 colleges, there's no building that has been put up labeled COSEXA, CANESCA, whatever. We use existing infrastructure. We use existing institutions of healthcare delivery to do our training. We are embedded in the communities. And our strength lies in that concept. But it means that some institutions may not meet the criteria for successful and appropriate training. So with an accreditation process, we say is what are the minimum requirements for an institution to be a center of training. Accreditation is sometimes viewed, and I've done many accreditation visits across the region, as something for people to be afraid of, as if they're undergoing an inspection. It's actually a means of verifying that the place is ready. But more than that, it's an opportunity to say what infrastructure, what equipment, what processes should you introduce for you to raise the bar, to perform at a higher level, to meet the actual requirements, not just of your trainees, but of the community that you're serving in healthcare delivery. So accreditation is a method that we have found in COSEXA to actually improve healthcare delivery. It is a method by which we uplift the quality of healthcare, the quality of educational training, the quality of educational learning. Next slide. Examples of collegiate bodies that are using this model of training, all of us are aware of the Oxbridge, Cambridge and Oxford, which run a large number of colleges with shared training curricula. In America, the University of California uses exactly the same model. And we know that within the United Kingdom, the various nations have got the Academy of Royal Colleges of UK and Ireland. But closer to home, in South Africa, they are now running their training using the Colleges of Medicine of South Africa, which is 29 affiliated colleges, of which urology, to which I belong, is one. And the interesting thing that the South Africans have done, which is really copying what the West Africans did many years ago, is to move from the MEd training program as the primary registrable clinical qualification to the college qualification. And this has resulted not only in uplifting the quality of the graduates, but it has created the opportunity for sub-specialization to the point that there are new specialties across the horizon, and there are new ways of handling old specialties that we have always had over the years. Next slide. So what did we create for our college, for our region? We created colleges, and I want you to think of colleges in the same sense that you think of faculties in the university. The University Senate, just as much as the Senate of the EXA CHS, cannot direct training at discipline level. You need the expertise which each college has based on its discipline to manage how students are recruited, selected, and then trained, and more important, examined. But we give them also the duty to ensure that professional development pathways are created and students are facilitated to pass through this so that they reach the pinnacle of their professional expertise and performance. They, by virtue of being professionals in a bigger environment, have regional connections and international connections that enable the colleges to perform at the level that they currently are doing. Next slide. Next slide, please. At EXA CHS, the East Central and Southern African Health Region is an umbrella body for the 11 affiliated institutions. The resolution of 814 established it, but we actually went through a process taking more than 2 years, and I'm proud that and feel honored that I was in that committee that actually put together the concept of the college. And we were looking at trying to create a body whose job would be to ensure that from the Health Ministers' Conference to the college level, there will be a mechanism where we are pushing forward the needs of the community. But also from the colleges would come the ability to continuously evaluate and re-evaluate the relevance of the structures that we had created, the performance of the graduate that we were passing through our hands, and therefore were impacting positively on health outcomes. CHS strengthens health education through a standardization of the training processes, assessments, and also in governance of the institutions. It strengthens health professional training and fosters knowledge sharing and standardizes health education in the region. And finally, CHS is driven by the need to maintain autonomy of the colleges so that each one of them remains founded on and embedded on the needs of each discipline. But together they work and collaborate so that we have a common legal foundation, we have a common operational approach, and we use the same educational frameworks to drive us. Next slide. The key features include that we have decentralized training approach. None of our countries has less than 60% of the population being based in the rural areas. And these are the people we are trying to serve. But if you look at all our universities, they are in the capital cities and the big cities. If you look at the distribution of specialists as we started, the lowest percentage was 81% in the big cities, and the highest was 93%. The collegiate structure says we should be delivering at the level of where the people are. So we are now moving and have emphasized the need to move to the district hospital level so that we are addressing the communities that we claim to and which we hope by the end of the next decade will be totally serving. It is a competence-based curriculum so that the training that we give is based on what do you need to do to service the client who is the patient, who are the communities that we are working on. Next slide. The college at Arusha serves to support the individual affiliated colleges in standardization, encouraging collaboration, in advocacy, and in administration. If I may just talk a little bit about administration, is that one of the things that we found as the new colleges came online was duplication of effort. We all have registrars. We all have administrative officers. But we don't need to have, if we end up with the South African model, for instance, 29 colleges, we don't need 29 administrators. So there's a shared overhead costs. But as we go forward, and I'll be saying this again, the future lies in digital training. Each college does not need to produce its own platform. That's expensive, time-consuming, and probably non-achievable for some of them. But if we have one platform that's created in EXA, then this enables all the other colleges to use the same platform to reach their students. And this is why we need CHS, and this is why at health minister's level, you need to invest in it so that it enables the colleges to be more effective and have a higher grade degree of impact. Next slide. CHS provides a support on governance and legal support. We encourage autonomy of each of the colleges, but we want to have a standardized governance framework. We want to have accountability that is measurable, sustained, and ensured. We need to have legal protection and advocacy at a common level. The important thing is that regional priorities, as envisaged by this conference, have to be expressed in how the colleges are teaching, what attributes, especially the soft skills, we are teaching our graduates, so that the graduates will embody and also explain the EXA priorities. For example, in this meeting we've been talking about universal health coverage. To what extent do our colleges represent that in their teaching, training, and the learning activities of their students? Health systems training, strengthening. How much does each individual college understand that and ensure that it's part of their curricula? And how much are we involved in policy? And it works both ways. The health ministers, you have the pressure that you get from your electorate that says, what do we need? To what extent is that reflected on what the training outcomes and attributes of the graduates are? But similarly, because these are academic institutions, they should be able to carry out research. What information are they making available to you so that your policies, thank you, are actually a reflection of what is actually needed? And to what extent are they involved in stakeholder engagement? Next slide. I'll rush through the next two because they are not that important compared to the last one that I'm going to go to. Quality assurance in any training program is one of the most essential requirements. And CHS enables the colleges to have a uniform approach to quality assurance, harmonized qualifications, which are easier for our registering bodies to actually adopt and implement. Accreditation, I've already mentioned, is one of our greatest strengths because of the way in which raises standards and also creates uniformity in performance. Next slide. We're here to capacity building, training support for institutions as much as it is for individuals. We need to be able to respond as a region to any changes in terms of disease patterns. For instance, 10 years ago, we were talking about trauma, road traffic accidents. How do we improve our response to it? Emergency preparedness, cross-border collaboration. But CHS has a specific role to assist in resource mobilization. EXA, by virtue of being a health community, is in touch with donor organizations, people with funds, and we hope that they will be very good at putting individual colleges in touch with people whose agendas are similar to what the college is interested in doing. We also would like to see them very heavily engaged in data sharing, research and knowledge exchange, especially research-based teaching. One of my sadness is that throughout my professional career, I've been teaching using textbooks based on Western European experience, based on American experience. Whereas our communities and our people do not necessarily behave that way. They also have their unique issues in terms of community and social response to illness. And we would like to see the textbooks that our students will be using in time to come to be based on our own research. Professional networks and digital platforms I've already mentioned, and this is the next slide. Next slide. This is the structure of CHS, which has got at the bottom its functioning committees and structures, and at the top, the Health Ministers Conference, to which we report through the Senate, which reports to the Secretariat, which reports to the Advisory Committee, and finally to HMC. Next slide is a repetition of the colleges that you have. Next slide. So what is it that we're asking you? Honorable Ministers and heads of delegations, we would like to ask you to commit to our colleges forever receiving the necessary support through the resolutions that you pass, but which you ensure they are implemented in the spirit and in the letter of the resolution. In 2007, this conference passed the resolution number 7 that said we are going to support the training of college students in every discipline. If I may digress a little bit, Madam Chair, and I'll try not to do it too many times, Coca-Cola has got workers, some of whom they recognize this chap will make a great manager and we want him to run the unit in town X. They develop him, they send him to courses, they pay for his attendance at those courses. They send him to Atlanta so you can see the mother body. Our own civil service recognizes performing individuals, sends them to development courses. But only in health do we ask doctors and nurses to pay for their own postgraduate development. There's something wrong with us. Let us support our students, and we said this in 2007, and all we are asking as colleges, we don't want you to give money to colleges, because that will create a bottomless pit. We want you to pay for a product. If a student needs to go and do a particular course, give him T&S support. If a student needs to go for examination, pay for his travel costs and his examination fee, and you get a certificate in return. So you're paying for a product. Zambia did this as the first group after we actually made this request in 2007, and the number of students in Zambia shot up. And I think all our countries need to do exactly the same thing. So we're asking you to support the students, but we're asking you also to support the colleges at EXA level. Senate, that is a statutory body, it needs to be supported directly from HMC. We have an issue whereby we train students, they qualify, and they can register. The statutory bodies in your countries are under your control as ministers. Please tell them to register your products. So ensure that national statutory bodies recognize and register the college qualifications in the various disciplines. I refer to South Africa having the colleges of medicines, where the primary registrable qualification for clinical practice is actually a college qualification, not the M.Med. If you have the college qualification, you are registered as a specialist surgeon. If you've got the M.Med, you can teach, but you can't use that for practice purposes. And that's precisely what, if you recall, 9 years ago, we met in Arusha. Incidentally, the chairman of the Health Ministers' Conference was actually the Republic of Malawi, and today we are again chaired by Malawi. And we agreed that when the colleges are in place, this is the move we shall make. From that list of colleges that I gave you, you actually noticed that we now have the 5 critical ones: surgery, medicine, pediatrics, obs and gynae, and anesthesiology. They are now in place, so we should now fix a deadline. By this date, the primary registrable qualification will be a college qualification. And that way we'll actually get the numbers, because the colleges can get the numbers. We'll get the practitioners who are where we need them. And there's a statistic I've shied away from saying so far, but if you look at all the college graduates, 93% have been retained in country. If you look at the university M.Med programs, we're almost down to 50%. What more do you need as evidence why you should support the college qualifications? The last request I'm going to make from the bottom of my heart, because I took part in all 3 outreaches that we did as EXA. We did medical and surgical outreaches to Swaziland, to Lesotho, and to Malawi. And in particular, the citizens of Malawi will remember that we spent a whole week at Cholo, which is about 41 kilometers south of Blantyre. I, as a urologist, we did 35 cases in that 1 week. But the outcome of it, which I really want to focus on, is that there were 2 student doctors who were general medical officers. They enjoyed that outcome so much. 2 of them now have got the COSEXA qualification as specialists. I'd also like to mention what happened in Swaziland, in Lesotho, where we had a matron, no less, who was almost wheelchair bound. And this matron had been going to South Africa for 2 years, back and forth, all this, all that, all that. When we came as a team, she had a total hip replacement done, and when we left, she was walking. These are the things that we do when we not only talk about saying we're saving the population, but we actually deliver to the population. It raises the profile of EXA Health community. It makes us relevant to the communities. And I would like us, we had good reasons why they were suspended, to resume the medical and surgical outreaches. With that, I would like to say thank you for listening. And this is how we say it in COSEXA using our local languages. And the last slide will be an acknowledgement of the people who contributed in making this presentation, and also a reference to the evaluation of our surgical camps, which is available as a publication. Thank you very much.
Thank you, Prof. Samkange. In these high-powered meetings, it's very difficult to say time up. Anyway, I've been making some summary notes to these 2 presentations, Prof. Samkange's presentation and the statement by Zambia, and I would want to say all the topics as presented are well articulated in the Global Health Workforce 2030. The country-specific examples from the presentation set the pace for us member states to benchmark where we are as regarding health workforce issues. Countries are at various stages of aligning their health workforce plans to this and their national strategies. It will be good to hear from member states the level of progress made in addressing the health workforce issues and the challenges. Member states can then benchmark against the other experiences from other countries. So, honorable ministers, distinguished ladies and gentlemen, I would want to call for comments, questions in the next 5 minutes before I close the session. Thank you. Mauritius.
Sorry, thank you. Madam Chair, when we are talking of investment in health workforce, I hear and from all sectors we are focusing on investing in our doctors, in our nurses, etc., etc. It takes a huge chunk of our national budget. Ours might be about 20% of our budget in health. But at the same time, when we are training our nurses, specialized nurses, we are adapting our training. We are trying to keep pace with our changes, especially climate change. But then the resultant is what? I have, on one hand, trained nurses, trained doctors. On the other hand, the open market, where they migrate, all my investment is lost. They move to Canada's and everywhere you can dream of. So what are we doing to motivate them to stay home? Condition of service, I suppose the condition of service is not bad in Mauritius, but what are the motivators we are trying to give? I suppose we should think about it. Along with the training, we need to have motivators, not necessarily financial motivators. Some other kind of motivators like advanced training for those who are very good. So, Chair, I will stop here so that we can think about it, what should we do to keep them. It's just like you grow up a child and he leaves you and goes in your neighbor's garden. Thank you.
Thank you very much, Mauritius. I will not open this for further discussion, but I want to really agree with you that it's a big challenge. We continue to invest in training and education, but the big elephant in the house, the gap is the retention, the sound retention strategy that the countries need to focus on. Thank you very much. Any other comments? Yes, Uganda, over to you, ma'am.
Thank you so much, and I want to appreciate the presenter for a very comprehensive presentation that was clear. I only have one issue that in the health sector, there is a tendency of normally not considering the community's participation. And we are moving towards the health at lower levels, prevention being better than cure. And this is where I think when we are talking about training health workforce, I do support it highly, but I think we should think how we should integrate the community education workers at the community levels, because they are our first foot soldiers, they are our first ears in the community, and as Uganda we are moving towards that. So when we are talking about training, let's involve the communities, let's involve our community workers at that level. Early detection is by these community workers. I thank you.
Thank you. Thank you, Honorable. Yes, I think we all agree with you. Integration with focus on community health workers, strengthening, training and education. We totally agree. And also not only training and education, but also retention of the community health workers. I'm looking for somebody who is itching to pass a comment or... Oh, sorry, Malawi.
Thank you, Chair. Thank you, Prof, for the wonderful presentation. I was keenly listening, and I think as countries in the EXA region, we've made significant strides with the colleges of various constituencies. Now, my point is on in this region of EXA, how best can we strengthen training of the workforce for the primary level care? Because as we stand now, I know that most of these cadres, they're being trained in the Orthodox colleges. What is the plan in the EXA region now to strengthen the capacity for our primary health care? Because we know that almost 75% of our disease burden, most of them can be prevented at a community level. What we've presented here probably might just be a tip of an iceberg. Have we thought through of how we're going to sort out the community level using the models that have been presented here? Thank you.
Thank you, Malawi. Yes, I agree. Education and training remain pivotal in improving skills base required at community level. And I would want Prof. Samkange, if you have a comment on what Malawi has just presented.
Thank you very much. You will notice amongst the 11 colleges is a College of Primary Care Physicians. And in fact, it's called Primary Care Practitioners. One of its mandates, which it has not explored to the extent that we would wish it to do, is actually to address training of primary care providers. We would like it, when they first started, they were thinking of primary care physicians as general practitioners. We really would prefer them to go to the lowest level, which is the community health workers, so that they are involved in the performance of community health workers, so that they're involved in the integration of the district hospital service, the satellite clinics, and the village level. And once that is done, our address of local needs will be met. You remember after the Alma Mater declaration, each one of us as countries came back and said, what are we doing and what structures are we creating at primary care level? And most of us actually created community health workers until we were misled by our advisors and took them off the government payroll. That was a very sad mistake, but we've learned from it and we are getting away from it. What we now need to do is to institutionalize all the levels of primary health care service delivery so that they are addressed in their individual needs and capacities. Thank you.
Thank you, Prof. Samkange. There's a request to add a few words from Dr. Shifa. You can go ahead, Dr. Shifa, 1 minute.
I think I'll come back to the key questions from our honorable ministers from Uganda and Malawi, and also the amazing presentation by Professor Samkange from the colleges. As I mentioned yesterday, the heart of our whole future, as you also heard from our honorable minister from Tanzania yesterday, and from this morning from her delegation, is primary health care. Reaching everybody, leaving no one behind. And public health, prevention, promotion, protection. I think this is the complete mindset change for equity and health for all, and all for health of our people in the region. And I think we need to really re-emphasize the re-strengthening, re-energizing primary health care with the community health workers, the health posts, the district hospitals, and the whole health services. I just want to emphasize that the 2 colleges which were launched last year in Arusha in June was the College of Public Health Physicians and the College of Primary Care Physicians. And we need to now work as a college with the whole system of the EXA College of Health Community to actually use the model which Professor Samakange mentioned, is how we all work at the primary health care, primary care, and the public health service delivery. Thank you.
Thank you, Dr. Shiva. At this moment, we have come to the end of the second session. Honorable, there's a hand. Oh, my apologies, Madam. Over to you.
Just in short, we know that most of our health skills workers are not preferring working within our respective countries. Most of them, we are seeing that they are shifting themselves, preferring working outside our respective countries. Maybe it is a time we could try to think on how we convince the diasporas, either coming back home or maintaining the friendship programs so that they can bring new skills from where they are working back to their respective countries. I think it is a time we could also try to think on these areas. But we are very much happy with our Excellency, Madam President in Tanzania, to make sure that we upgrade skills for health workers in professional areas. Madam President has decided to set aside every year a special budget for upgrading skills for all areas for health workers within our country. Up to this moment, within 3 years, we have already spent almost 30 billion Tanzanian shillings to make sure that we trained the professionals within the health sectors.
Thank you, Honorable. I totally agree, and I know the rest of the members agree also to what you have just said. Now that Zambia is close to me, I can't say, yes, I can't say no, he's my brother from the other mother. You can take the floor for 1 minute.
Thank you, Madam Chairman. I think we need to look at the picture of retention of our young men and women as a whole. When they come back to our hospitals, what they find in our hospitals? They find the equipment is out of service to say. They have no medicines. The service to the staff, to the hospitals, to the patients is in bad step. They go outside to the schools for their children. There are no schools for them to go. So really find that it's not only about being doctors. It's being family people. What they get from us when they come back to our countries compared to what they're getting outside the country that we're talking about. So I think we need to look at this issue, not only as the doctors, but as the educational means of educations, the schools that they go to, the transport that we give them, so all these things need to be looked into as a whole, rather than just look at them as doctors when they come back from where they are. Thank you.
Thank you, Zambia. He's still emphasizing on the issue of coming up with the sound retention strategies. Thank you. Honorable Ministers, allow me to close this session. It has been a great pleasure and honor to be driving the show, chairing the 2 sessions. Thank you very much. We have come to the end of this session.
Thank you very much, Zimbabwe, for moderating these 2 sessions. Let's give her another round of applause. I know we haven't done well in terms of time, but I could see the pressure that she had. She couldn't let some of the sessions to be let go like that, but thank you so much, and also let's give a round of applause for the presenters. They have done quite well as well. Thank you so much. Now I think it's time for our morning break. Let us have our refreshments, the same place that we had yesterday. Our time is around 11 minutes past. We are supposed to start this next session at 11:30. Let's keep time. Thank you so much. Session adjourned.
You made us proud. Thank you. It's a key session. We will try and take it forward to some decisions and resolutions.
Thank you so much. Actually, we need to have more Thank you so much.
Yes, I feel like I want to end my life with a tiny pill. Yes, sometimes I just want to end it with a tequila shot. But all day.
5 decades of relentless dedication to regional health and cooperation. Established in 1974, EXA-HC emerged from a visionary convention of health ministers uniting countries to foster regional collaboration in health.
The East Central Southern Africa Health Community is an intergovernmental regional health organization that was founded in 1974 as the Regional Health Secretariat for the East Central Southern African region under the Commonwealth Secretariat.
Originally under the Commonwealth Secretariat, it has evolved into a dynamic regional platform. Hosted by the United Republic of Tanzania, EXA-HC has become a vibrant hub for its 9 active member states, and that include Kenya, Lesotho, Malawi, Mauritius, Kingdom of Eswatini, Tanzania, Uganda, Zambia, and Zimbabwe.
The mission of the organization has remained the same since establishment, which is the focus on fostering regional cooperation in health among member states.
Over the years, EXA-HC has undertaken transformative projects, expanding its reach and impact.
It has grown by leaps and bounds for program clusters and a number of standalone projects delivering on the broad health agenda. Presently, we address 8 broad areas in our programming. We focus on family health, that includes the whole area of reproductive, maternal, neonatal.
50 accredited trainers. In the heart of Africa, the East Central and Southern African Health Community, EXA-HC, stands tall, celebrating 5 decades of relentless dedication to regional health and cooperation. Established in 1974, EXA-HC emerged from a visionary convention of health ministers uniting countries to foster regional collaboration in health.
The East Central Southern Africa Health Community is an intergovernmental regional health organization that was founded in 1974 as the Regional Health Secretariat for the East Central Southern African region under the Commonwealth Secretariat.
Originally under the Commonwealth Secretariat, it has evolved into a dynamic regional platform. Hosted by the United Republic of Tanzania, EXA-HC has become a vibrant hub for its 9 active member states, and that include Kenya, Lesotho, Malawi, Mauritius, Kingdom of Eswatini, Tanzania, Uganda, Zambia, and Zimbabwe.
The mission of the organization has remained the same since establishment, which is the focus on fostering regional cooperation in health among member states.
Over the years, EXA-HC has undertaken transformative projects, expanding its reach and impact.
It has grown by leaps and bounds for program clusters and a number of standalone projects delivering on the broad health agenda. Presently, we address 8 broad areas in our programming. We focus on family health, that includes the whole area of reproductive, maternal, neonatal, adolescent, and child health, the whole gamut of infectious diseases, although lately we have been very focused on aspects of TB and responding to pandemics and emergencies. We look at non-communicable diseases, we look at food security and nutrition, we look at elements of human resource capacity development, we also look at health system strengthening, we look at the whole area of knowledge management, but we also focus on monitoring and evaluation.
In line with the global call to improve human resources for health, the EXA Health Community formed colleges to address HRH issues in the region.
The good thing about the Cluster for Health System and capacity development that is a fully developed cluster that have demonstrated good results in various areas. If you look at the number of specialized human resource that has been produced within the umbrella of the College of Health Sciences is quite enormous, and this is actually contributing greatly to the advancing that the region as well as the individual member states are making in respect to universal health coverage.
At present, there are 9 colleges providing various specialized training. This training model has contributed significantly to the HRH development in the region. Together, they reach over 20 countries, having more than 140 accredited training sites. COSEXA, being the largest college, has trained over 1,500 surgeons with 744 accredited trainers and graduated over 910 surgeons. EXACOP has over 540 fellows and 150 accredited trainers. The retention rate has been noted to be over 90% in the region.
The main purpose of establishing the College of Surgeons as health ministers was to bridge the gap between the patient and the surgeon. There was a shortage of specialized surgeons in the region, but also there were challenges of brain drain where medical doctors would go to other countries, high-income countries, to seek advanced surgical training, and they would not return. Secondly, for few institutions that were offering surgical education, which was MED, the trainees or the students were paying quite a lot of money. So the reason they were looking for a solution which is home-based is to offer cheap education in surgical training, also curb down brain drain, and use the existing resources within the region, whereby we are able to train in hospitals in different countries.
In the journey towards improving health outcome, EXA-HC has made remarkable strides under the reproductive, maternal, neonatal, child and adolescent health cluster. This significant progress reflects EXA-HC's unwavering commitment to addressing critical health challenges and enhancing the well-being of the communities across the region.
The health of women, children, and adolescents remains a very high priority for us in the East Central and Southern Africa region. We note from recent data that quite a lot of progress has been made in reducing maternal deaths as well as under 5 mortality. For the EXA region, we are talking about reductions around 34% for maternal mortality and 51% for under 5 mortality over the last 2 decades. Now, this is appreciable and significant improvements in health indicator, but we have to be quick to say that the EXA region remains among those that have the highest maternal mortality as well as child mortality. And for this reason, the EXA health community has continued to prioritize aspects of maternal health, child health, and adolescent health.
In the heart of communities where the medical care was a distant dream, EXA-HC Surgical Camp emerged as a lifeline, offering free surgeries to those in dire need. For example, the story of Pure Nkosi.
A few years back, we were privileged to operate medical surgical camps. We traveled, a group of experts from member countries and beyond. We went to Lesotho, Queen Mama Hospital. We treated all the patients almost for free to our local governments, but everything else was organized by the EXA secretary. The last job. I'll never forget a young boy who had bilateral cleft lip, and that was a very, very unique cleft lip, that the clefts went all the way to the lower eyelids. So it was like, what are we going to do? But because of the experts that were there, we got involved into helping bring the tissues together, and his name was Pure Nkosi. I can't forget because it's something that I did myself together with a few surgeons. And the next day, the boy had pulled out all the supports that were given in for him to breathe in and all those kind of things. It worked very well. And then we went to Malawi. We worked from Cholo Hospital. We had a group of elderly men that had issues with their urinary system who could not have received the treatment had we not gone there. And because it worked so well, and at places where we did not have appropriate medication, we improvised. And all patients that were touched by us, from medicine to surgical, obstetrics gynecology, came out very well. That is the strength that is at our disposal. It just needs to be tapped. All the experts were homegrown from the region of X. And I want to believe if this is going to be called out every other time, each of our countries, we shall benefit.
As we wrap up this documentary, we celebrate EXA-HC 50 years of impactful work. Our heartfelt thanks go to our dedicated staff, member states, partners, and donors. Your unwavering support and collaboration have transformed countless lives and driven regional health advancement.
As we celebrate the 50th anniversary of the EXA Health Community, I'd like to take this opportunity to wish you all a very happy Golden Jubilee of EXA, and to thank everyone who has been part of EXA for the past 50 years, including all the member states and their populations, the Secretariat, all our partners, and everyone who has been part of EXA. At the same time, I wish to take this opportunity to remember all those who are no longer with us, but who played a key role in the success of EXA.
Together, we look forward to building a healthier, more resilient future for all. Thank you for joining us on this journey. In the heart of Africa, the East, Central, and Southern African Health Community, EXA-HC, stands tall, celebrating 5 decades of relentless dedication to regional health and cooperation. Established in 1974, EXA-HC emerged from a visionary convention of health ministers uniting countries to foster regional collaboration in health.
The East Central Southern Africa Health Community is an intergovernmental regional health organization that was founded in 1974 as the Regional Health Secretariat for the East Central Southern African region under the Commonwealth Secretariat.
Originally under the Commonwealth Secretariat, it has evolved into a dynamic regional platform. Hosted by the United Republic of Tanzania, EXA-HC has become a vibrant hub for its 9 active member states, and that include Kenya, Lesotho, Malawi, Mauritius, Kingdom of Eswatini, Tanzania, Uganda, Zambia, and Zimbabwe.
The mission of the organization has remained the same since establishment, which is a focus on fostering regional cooperation in health among member states.
Over the years, EXA-HC has undertaken transformative projects, expanding its reach and impact.
It has grown by leaps and bounds for program clusters, a number of standalone projects delivering on the broad health agenda. Presently, one could say we address 8 broad areas in our programming. We focus on family health. That includes the whole area of reproductive, maternal, neonatal, adolescent, and child health, the whole gamut of infectious diseases, although lately we have been very focused on aspects of TB and responding to pandemics and emergencies. We look at non-communicable diseases, we look at food security and nutrition. We look at elements of human resource capacity development. We also look at health system strengthening. We look at the whole area of knowledge management. but we also focus on monitoring and evaluation.
In line with the global call to improve human resources for health, the EXA Health Community formed colleges to address HRH issues in the region.
The good thing about the Cluster for Health System and capacity development that is a fully developed cluster that has demonstrated good results in various areas. If you look at the number of specialized human resource that has been produced within the umbrella of the College of Health Sciences is quite enormous, and this is actually contributing greatly to the advancing that the region as well as the individual member states are making in respect to universal health coverage.
At present, there are 9 colleges providing various specialized training. This training model has contributed significantly to the HRH development in the region. Together, they reach over 20 countries, having more than 140 accredited training sites. COSEXA, being the largest college, has trained over 1,500 surgeons with 744 accredited trainers and graduated over 910 surgeons. EXACO has over 540 fellows and 150 accredited trainers. The retention rate has been noted to be over 90% in the region.
The main purpose of establishing the College of Surgeons as health ministers was to bridge the gap between the patient and the surgeon. There was a shortage of specialized surgeons in the region, but also there were challenges of brain drain where medical doctors would go to other countries, high-income countries, to seek advanced surgical training, and they would not return. Secondly, for few institutions that were offering surgical education, which was MED, the trainees or the students were paying quite a lot of money. So the reason they were looking for a solution which is home-based is to offer cheap education in surgical training, also curb down brain drain, and use the existing resources within the region, whereby we are able to train in hospitals in different countries.
In the journey towards improving health outcome, EXA-HC has made remarkable strides under the reproductive, maternal, neonatal, child and adolescent health cluster. This significant progress reflects EXA-HC's unwavering commitment to addressing critical health challenges and enhancing the well-being of the communities across the region.
The health of women, children, and adolescents remains a very high priority for us in the East Central and Southern Africa region. We note from recent data that quite a lot of progress has been made in reducing maternal deaths as well as under 5 mortality. For the EXA region, we are talking about reductions around 34% for maternal mortality and 51% for under 5 mortality over the last 2 decades. Now, this is appreciable and significant improvements in health indicator, but we have to be quick to say that the EXA region remains among those that have the highest maternal mortality as well as child mortality. And for this reason, the EXA health community has continued to prioritize aspects of maternal health, child health, and adolescent health.
In the heart of communities where the medical care was a distant dream, EXA-HC Surgical Camp emerged as a lifeline, offering free surgeries to those in dire need. For example, the story of Pure Nkosi.
A few years back, we were privileged to operate medical surgical camps. We traveled, a group of experts from member countries and beyond. We went to Lesotho, Queen Mama Hospital. We treated all the patients almost for free to our local government, but everything else was organized by the EXA Secretariat. Then we moved into the Kingdom of Eswatini. We did a marvelous job. I'll never forget a young boy who had bilateral cleft lip, and that was a very, very unique cleft lip, that the clefts went all the way to the lower eyelids. So it was like, what are we going to do? But because of the experts that were there, we got involved into helping bring the tissues together, and his name was Pure Nkosi. I can't forget because it's something that I did myself together with a few surgeons. And the next day, the boy had pulled out all the supports that were given in for him to breathe in and all those kind of things. It worked very well. And then we went to Malawi. We worked from Cholo Hospital. We had a group of elderly men that had issues with their urinary system who could not have received treatment had we not gone there. And because it worked so well, and at places where we did not have appropriate medication, we improvised. And all patients that were touched by us, from medicine to surgical, obstetrics gynecology, came out very well. That is the strength that is at our disposal. It just needs to be tapped. All the experts were homegrown from the region of X. And I want to believe if this is going to be called out every other time, each of our countries, we shall benefit.
As we wrap up this documentary, we celebrate EXA-HCE 50 years of impactful work. Our heartfelt thanks go to our dedicated staff, member states, partners, and donors. Your unwavering support and collaboration have transformed countless lives and driven regional health advancement.
As we celebrate the 50th anniversary of the EXA Health Community, I'd like to take this opportunity to wish you all a very happy Golden Jubilee of EXA, and to thank everyone who has been part of EXA for the past 50 years, including all the member states and their populations, the Secretariat, all our partners, and everyone who has been part of EXA. At the same time, I wish to take this opportunity to remember all those who are no longer with us, but who played a key role in the success of EXA.
Together, we look forward to building a healthier, more resilient future for all. Thank you for joining us on this journey.
Hello. Let's get seated. Welcome back. Welcome back, team. We need to manage our time. Let's get seated. Let's get seated so that we manage our time. Hello, at the back. Let me welcome each one of you to our third session for the day. And this is session 7. This is a higher-level ministerial session on NCDs and mental health. So our moderator this session is Mauritius. May I hand over to Mauritius to take it up. Over to you, sir.
Thank you. I suppose I don't need introduction. Thank you. So, as usual, I'm going to talk about NCDs and mental health. I suppose for the last 20 years, everyone has been talking about NCDs. But very little attention has been given to mental health. I mean, I'm not a doctor, I'm not a health professional, I'm an administrator. The question I ask, is mental health a disease or is it a condition? I would consider that a condition which can be fixed. Once I say it's a disease, this becomes complicated. All our doctors, nurses start running and you get more complicated. I'm sorry. So let's consider this as a condition, and the condition is to make sure that mental health is getting a priority in all the governments. We used to say that, you know what, mental health hits you at later stage. A lot of teenagers in my country, in Mauritius, are facing with mental health. I won't say due to smartphone and etc., but because of TikTok, WhatsApp, Facebook. They are so much drugged, I'm using this term, they are drugged by this, so they don't know what to do. And once the internet goes off by 15 minutes, they become a mental condition. I'm sorry to put it like that. I have 2 daughters, so I know what it means. All I'm saying is we have to find the root causes. The problem is there. It's a question of recognizing mental health. Recognizing is the first step towards fixing. So this is my understanding of NCDs and mental health. Now I'm going to invite the Secretariat for the overview of the NCD and mental health in the ESC-SC region, please, for the presentation.
Thank you very much, Chairperson. And thank you very much once again for that wonderful introduction in terms of NCDs and mental health. Honorable Ministers, heads of delegation, so I'm presenting on behalf of EXA Health Community as a secretariat. So this presentation will mainly dwell on non-communicable diseases. We have a separate session where we talk about mental health. We have a panel discussion. As the chairperson has already alluded to, these are 2 issues that we have to actively get involved, understand them, and let's see the resolutions that we have. So we are addressing non-communicable diseases as a public health emergency in the EXA region post the Golden Jubilee. Our colleagues, when they're presenting about tropical diseases, they talked about an elephant in the room. Probably that one is the first elephant. The second elephant are non-communicable diseases. We all see this elephant in this house, but we are failing to push it out of this conference room. So I believe by the end of this presentation, heads of delegations, honorable ministers, this is something that we will seriously consider and make sure that we take this to the next level. Honorable ministers, non-communicable diseases, they have reached that epidemic proportion. Yet these are diseases that can be, largely prevented. Actually, every year, non-communicable diseases, they're pushing 100 million people into poverty. You agree with me that they are straining our health systems. If you were to ask the hospital directors who are here, the directors who are, they will tell you that probably if you look at the bed occupancy for most of the facilities, it's because of non-communicable diseases. It's either patients have stroke, cancers, or injuries. Because most of the communicable diseases probably we have done very well. But as I've said, this is the elephant that we have to deal with now. Even literature is telling us that if we do not do anything, come 2030, non-communicable diseases will overtake all communicable diseases, and it will be Africa's leading cause of death. However, even if we have this, WHO, we have the SGD 2030 3.4, where we're talking about reducing premature mortality due to NCDs by 33.3%. But as a region, we haven't done very well. We need to actually accelerate the implementation of the activities that will lead to the reduction of this premature mortality. So this is the time that as a region we can do well when it comes to preventing non-communicable diseases. Well, I assume I'm preaching to the converted who are aware what non-communicable diseases are. These are diseases that cannot be passed from one person to another. Actually, these are conditions that tend to be of long duration. These are diseases that are caused by some physiological, genetic, environmental, as well as behavioral factors. However, these behavioral factors, we have that liberty that we can modify them and make sure that we reduce the prevalence of non-communicable diseases. Like last night when we were having a cocktail, I think I mentioned something about harmful use of alcohol. I'm happy, Chair, to report that the acting DG this morning told me that I controlled people. No one did binge drinking. That was very good. I think we addressed one of the modifiable risk factors of disease. And tobacco use, this is something that is within us. We can control it to say, well, we want to reduce the prevalence of non-communicable diseases. Physical inactivities. I know if we were to ask the team here to say, look, after the session, we want people to put on, sports clothes. Let's move around the Capitol Hill. We ask the Principal Secretary from Ministry of Health. Most of us will say, no, I don't have time for activities. Even some tell you that, well, I walked a lot when I was young. But this is something that we have to do now. Unhealthy diet. We are happy as the EXA Health community. We developed an adolescent nutrition advocacy strategy. So we want to start from the adolescents, that as they are growing, we address the non-communicable disease. We do believe that if we intervene right now, come next generation, the prevalence of non-communicable diseases will be low. I've already talked about non-communicable diseases, they do kill. You agree with me? If I were to ask everyone in here to say, turn to your right, ask your neighbor, do you know anyone with a non-communicable disease, or are you affected? And even to the left, you find that most of us, we know someone who is affected. You find that maybe most of us, we have a condition. So these are diseases that are attacking the productive age group. If you look at the graph here, look at the blue. These are deaths that occurred, that happened due to non-communicable diseases. And basically, if you look at the age group, it's 30 to 69 years. This is the productive age group where most of us belong. We are, the ones who are driving the economy of our countries. So if we are affected by non-communicable diseases, that's why I said non-communicable diseases are pushing 100 million people into poverty every year. So this is the time that this age group should act upon to make sure that we do not get non-communicable diseases. As I said, globally, non-communicable diseases are leading in terms of deaths. About 74% of deaths are due to non-communicable diseases. In 2021, 41 million people died due to non-communicable diseases. And the issue is 85% of those deaths, that was a premature death, a death that could have been avoided. And unfortunately, 86% of these deaths happened in low and middle income countries, which most of us do belong. So this is something that we have to deal with now. And look at that. Every minute, 32 lives are lost before the age of 70 due to a non-communicable disease. Unfortunately, 28% of those deaths happen in our countries, low and middle income countries. So that's why I said this is an elephant in the house, but we tend to ignore it because it's silently killing people. So we need to make noise about non-communicable diseases. Chairperson, if you look at this graph, as the EXA region, the 9 countries that are in the EXA healthy community, the population is 256 million. But if you look at the way we in terms of premature deaths when it comes to NCDs. The 2030 agenda, the one I talked about, the SGD 3.4, where it's saying we should reduce premature mortality due to NCDs. For countries that we have in the region, I'm sorry to say, the picture looks gloomy. Instead of going downwards, we're going upwards. Probably 2 countries, they have slightly done well, but not to the level that we are looking for. Let's look at Tanzania and Uganda. Because in 2018, like Uganda, the prevalence, sorry, because I can see on there. If you look at the premature mortality rate for Tanzania, in 2018, it was around 18%. But they have done well because 2022, it was 17%. Of course, if you look at the target of the SGD 3.4, it's that we should reduce it by 33.3%. So in 2030, Tanzania, we expected that it should, the premature mortality rate due to NCDs should be around 12%. But let's look at other countries. For example, I'll mention Lesotho. Look at the chairperson, look at the bar graphs. In 2019, we're at around 28%. By 2022, it's 42%. By 2030, we expect Lesotho to be around 18%. Is this something that we can achieve? But if you look at the risk factors that are contributing to most of these, for example, it's the use of tobacco, which I said this is something that we can control as member states. We do believe that if we can address these modifiable risk factors, we should be able to achieve SDG 3.4. So this is the situation that we have as a region, honorable ministers and delegates. Now, we committed to the SGD 3.4 that we will achieve SGD 3.4. So with the bar graphs that I showed, are we sure as a region we'll be able to achieve this? I do believe we can. If we work as a bloc, if we work as a team. So, how do you think we can accelerate to achieve this agenda? Number one, we need that commitment of highest political office to NCDs. We need all of us to make sure that we make NCDs everyone's responsibility. Make sure that you understand what NCDs are. If you see somebody that they have these modifiable risk factors, give them an advice. Even ourselves, it starts with us. It can start even today. Make sure that we change our lifestyles. I've talked about nutrition. Let's watch what we eat. Give some time for us, to do some physical activities. If you take alcohol, like what I said, I would advise moderately. Or if at all, if you can manage, just stop taking alcohol. Then we're good. And for tobacco smoking, I advise that we should quit smoking. So, honorable ministers, chairperson, what I'll ask as a secretariat, we would like this conference to declare non-communicable diseases as a public health emergency in EXA countries, which we are aware some countries are going towards that. We do believe that if we commit ourselves to this, we should be able to address this. And if we can engage the 9 heads of state or government to invest, accelerate, align, and account for implementation towards the SGD 3.4, we should be able to achieve this. Let's give the necessary skills to our healthcare workers for them to manage patients. And our colleagues on combating tropical diseases, their elephant was the financing. For us, we said the financing is the whole NCDs. But probably we can also add a small elephant, which is the same, financing. Non-communicable diseases in most countries, they have been underfunded. Probably because, as we said, these are diseases that are chronic, long duration, and mostly we don't see the impact. But as I said, they affect our health systems. So if we can have a mechanism of funding non-communicable diseases, make sure that we address them. Let's say we advocate. We talked about primary health care. This is the time. If we talk about those things, surely we should be able to address non-communicable diseases. So, Chair, let me leave you with this quotation from one of the statesmen in the region, Nelson Mandela. It always seems impossible until it is done. People may think this cannot be done. We have seen other countries involving heads of state. Once the head of state says non-communicable diseases, it's a challenge, and the head of state starts working, doing physical activities, almost all of us here will join. If I ask people to say, can we do physical exercise? They'll tell me that, well, we walked a lot when we were young. So if we engage the heads of state, make sure we declare this as a public health emergency, we should be able to achieve SGD 3.4, which is telling us to, reduce the premature mortality by 33.3%. Thank you very much, Chairperson. Let me, before I hand it over to you, Chairperson, we have champions who have been advocating about NCDs. Some of them are in this house. We have Dr. Temo, who is from NCD International, all the way from Geneva. We have Dr. Shiva, who are with the Public Health College, which is also advocating about non-communicable diseases. So this is what as Secretariat prepared to share with you, Chairperson. Thank you very much.
Thank you very much. Well, your presentation was too clear for us not to understand. NCD is a problem. 6 years ago when I came to the Ministry of Health, when they told me NCD, I said, what is this NCD? It's a given. We accept it as being something part of our life, which is not. We should challenge it and make sure this happens. So with these words, I would invite the next presentation on HPV, prevention and cervical cancer management. I understand it's from the World Bank Gates Project. 10 minutes, please. It's in the program, right? They are not here. Maybe we can... the youth advocate. Or before we do that, maybe we can give people who want to react to the first presentation. They're not coming this week. No. Okay. Okay, sorry. I have just been advised they are busy in the prevention of HPV in field work. So we recognize that there's some important things that we need to do. But from my side, I would like to say, from our experience, we recognize that HPV vaccine is very important. We started, I won't say forcing our youngsters at school level to do it, but motivating them, because the ultimate resultant of all this is cancer. So we are trying to prevent it, and we are making sure that our children are fully aware, they are vaccinated for that. With this word, I will ask my honorable ministers and colleagues to react on the first presentation. We take 5 minutes for that, then we'll go for the next thing. Thank you. I open the floor. Yes, my colleague from Uganda, please.
Thank you so much, Chair. And I want to thank the presenter. And I want to recognize that non-communicable diseases are on the rise in all our member states. What is at stake as member states or those in government, of course, is that we know the causes, we know management, we know the treatment. When we are here, I think the presenter, if I'm not wrong, he asked all of us to stand up and he tests those who have got high pressure and low pressure. And I noticed, I think like 4 people participants, they jumped from their feet. The rest is just we are standing on our feet. You know, I'm very good at recognizing. Me inclusive, I remained on my 2 feet. And here, physical inactivity is a very big problem if we are to manage. Tobacco, alcoholism. Yes, we are here listening good topics, and I'm sure there are some of us who are about to run away and saying that at what time are we ending? I saw a dinner somewhere. You'll see how many are going to consume the alcohol. We must walk the talk. Finally, the issue of our lifestyle. I want to emphasize it. How were our own parents and generations doing? Our lifestyle, the problems that are connected with our lifestyle. We must change that. You'll find you are spending a lot of money in medical tourism to manage obesity, our lifestyle. And the hypertension, diabetes, and all of these, they are also connected to the way we are living. So my final request is that as African states, these are preventable diseases, but they take a lot of money. A lot of money. And it is high time that we strategized back again to the communities and we start from there. And it will help us to save money, the infrastructures we are putting up. And on that note, I want us that to go as per request, that we make it a public health threat. In Uganda, we have a minister in charge of public health care. That is already a political will to manage all these public health problems that we are facing. I thank you.
Thank you, Madam. I fully agree with you. I still have something that it has been told for years and centuries that a glass of red wine is good for health, and doctors vouch for it. Now I question myself. Thank you, Madam. Now I will invite anyone else who wants to comment on the presentation. Good. So I can't find anyone, so it seems everyone understood the issue of NCD and how it is and should become a higher priority. Resources are important, but our human resources are more important than anything else, everyone. So we'll proceed to the next part, is the statement by a youth advocate on adolescents' mental health. It is from Commonwealth Youth Forum for 10 minutes. Thank you.
Thank you, Honorable Chair, Honorable Ministers, and Heads of Delegations, all protocols observed. First of all, I would like to express my sincere appreciation to EXA Secretariat to allow a young voice to speak and share our health needs at the 74th Health Ministerial Conference. Asanteni sana. My name is Salome Mosha. Youth Representative Commonwealth Youth Health Network from Tanzania. And I'm here today representing many youth from the 56 Commonwealth countries, especially the EXA region. But I'm here today to raise a voice of young people on a silent pandemic of mental health disorders in our region. Honorable ministers and delegates, we as the young people, we have recognized that mental health is a serious issue that needs to be addressed. As I make my presentation today, my plea to you, honorable ministers, is to make a conducive environment for us to be supported adequately. So the Commonwealth Youth Health Network is where I come from, is one of the initiatives among 13 networks housed within the Commonwealth Secretariat. And it represents youth from the Commonwealth countries aged 15 to 29 years of age. And its main aim is to promote a greater recognition of the role of young people's participation in the health sector. This network is supported by the Secretariat through the health team, and by saying that, I want to recognize Dr. Janet Mgamba, who is here with us today, Health Advisory Commonwealth Secretariat, who has been with us. She's our mentor in this project. As CYHN, we raise our voices through a formalized Commonwealth Youth Council and elevate these voices to high-level meetings of ministers and head of government, as such as today's session is one among the sessions. Honorable ministers and head of delegations, as I move to my presentation, I want you to take just a few minutes to look at that young person there, that young man, and to read that quote there. That young man looks stressed, sad, and he has no one to talk to. As I read the quote, something crossed my mind, and that is the urgent need to address the often hidden struggles of adolescents facing mental health challenges. Honorable ministers and head of delegates, to frame my discussion today, I would like us to do a very simple exercise. Could you please turn to your immediate neighbor and just ask them a very simple question? How are you? Thank you, honorable ministers and delegates.
Some people are asking for a glass of wine now.
Oh, so I'm very sure most of them responded with, I'm fine, or I'm okay, or I'm doing well. So I'd like to take this time to play a video that will portray the underlying and often hidden issues that the young people must can carry. And this may even question your response.
I am fine. Yes, I feel like I want to end my life with a tiny pill. Yes, sometimes I just want to end it with a tequila shot. But we're all day after lunch, so I choose life. I'm fine. I won't hesitate to smile when you wave at me to say hello. I won't hesitate to take a selfie every time I feel pretty. Yet the words of my heart are being shattered, and I can feel them fall apart. But I'm fine. Do I not dress to kill in word and smile? Do I not attend the parties and then still I get no more? Yet I get it hard to catch my breath at night and when I let it all go. But don't worry, I'm fine. I will always give you a hand every time you need me. I will listen to your cries and lend you a shoulder to cry on. I will bring you flowers to celebrate your triumph. I will always be there to let you see that I'm fine. I will always convince you about the beauty in losing weight. I will encourage you to exercise and look perfect in shape. But I will never tell you that my loss of weight ain't because of dieting or exercising, but rather the pain that is eating up my soul. But anyway, I'm fine. I will always fight for my last breath because Mom taught me to be better. I will look perfect and fancy around you. I will take advantage of snapshot and paint the words with beautiful colors. And you're sure you always think I'm fine. I'm not going to cry to you or wear my depression. I don't do pity and I refuse to look. I'm not letting my feelings reflect to the world that calls me perfection. I will always look perfect for you. Is that what you like? So, I'm fine. I will live this life the way you want me to. I will cry in public. No, not lose my reputation. I will wear a perfect smile and beauty. And if I'm to take my last breath, I will take it in a perfect way. For I am fine. And I am Miss Perfect.
Thank you very much, Chairperson, Honorable Ministers. So this is a poem done by our fellow Commonwealth Youth Health Network from Rwanda called Anna Gaela. And do you know what they say about us, about the young people, about the Gen Z? They say that is the third generation with happy pictures. But this is because we have no room or dedicated spaces to voice our concerns. Yet, the society needs us to show that we are okay, that we are perfect, but we are not. This video is a call for a shift in how we relate with our young people and mental health issues. It is a cry to transform them from silent struggles into vocal policies that actively empower young people. And these policies should acknowledge the complexity of our identities, recognized by our unique experiences, shaped by our age, background, and societal pressure. Ultimately, our goal is to create a supportive environment where young people in EXA region can voice their concerns and receive the help they need to thrive. You may ask yourself, why addressing mental health issues? So according to WHO and UNICEF report of 2024, it shows that 1 out of 7 adolescents aged 10 to 19 experience mental health conditions. And this accounts for 15% of global burden of disease in this demographic. Mental health disorders such as depression, anxiety, and behavior disorders were the leading cause of illness and disability among adolescents. In addition to that, suicide being the third cause of death. Surprisingly, this number of cases remain untreated, and it's due to stigma and limited access to care. So some of the factors mentioned associated with mental health were poverty, abuse, and violence. So if we look in a global perspective, the problem of mental health is mostly caused by anxiety, depressive, and conduct disorders. But regionally, as youth from the EXA, we have made some efforts to fight the mental health struggles our peers face, such as creating safe spaces online where we publish blogs on the urgent call to action on mental health and conduct awareness creation dialogues. There is this book, Honorable Ministers, at your desks. For those who have not get this copy, they are there outside. You can just pass by and get your copy. It explains more in here. So by doing that, we recognize that it is not enough. Therefore, in April through May 2023, as a member of CYHN, we set to conduct a situation analysis on the mental health status of young people in East Africa, whereby 277 youth participated from 4 East African countries: Tanzania, Kenya, Rwanda, and Uganda. The objective of this analysis was to assess mental health status, attitude, and access to care among Commonwealth youth in East Africa. So the results showed that 24.9% reported previous history of mental health conditions, mainly depression. And the primary factors that caused to these issues were family issues by 48.4% and unemployment by 23.4%. We also looked into other factors that contribute to mental health disorders, and we measured the level of youth feeling distressed, and 80% responded often feeling distressed. We also measured level of sleep and level of concentration. And level of sleep, 22% responded having difficult time falling asleep, while level of concentration, only 53% could concentrate in an hour. So other factors that contribute to mental health issues are relationship challenges, stress, unmet life goals, trauma, societal pressure, and social media, whereby 70% of youth that responded to our analysis use 2 hours daily on social media. So we also looked into attitude and willingness to seek help, whereby 99.4% consider that mental health is a serious issue that needs to be addressed. 96.4% believe that mental health can be treated and prevented. Also, 98.9% they are willing to seek mental health services. We also prompt a suggestion to open a web-based consultation service, and 96.4% agreed. So our survey had some of the limitations, as it was an online survey, but also we only got 277 participants, so we did not really feature a whole group of youth in EXA region. So the main takeaway of our analysis is that many youth from the East Africa face mental health challenges, such as depression and distress, but they have issues. Their main factors were family issues and unemployment. So as parents, I know a lot of you are parents here. Family issues are the leading cause that associate with mental health to adolescents. So we really have to question ourselves how we live with youth in our households, how we treat them, how we listen to them, how we understand their concerns in this generation. So in understanding the graphic of this challenge, the EXA Health Community, in partnership with the Commonwealth Secretariat, launched a regional mental health youth lead project in November 2024. And this project addresses the increase of mental health challenges facing youth in EXA region by the use of sport, health, arts, and culture as the tools to empower young people to share their experiences and co-create solutions towards a healthier EXA. And this aligns with the Sustainable Development Goals and the regional commitment to health improvement. So that was a picture during the launch of the regional youth-led project at Arusha. So as I'm going to conclude my presentation today, honorable ministers and head of delegates, our plea as youth from the EXA region to you are, on the national and communal level, we call to strengthen capacity building by training and developing mental health workers at community and facility level, to enhance awareness through social media and peer networks, also to establish a young-focused counseling network in collaboration with professional bodies, and to invest in youth-friendly sports and health services by engaging educational institutions and communities. On a regional level, to develop a holistic regional framework for mental health by integrating multiple sectors and establish regional youth centers for youth to voice their health policies, in which we have already started with EXA in the regional youth-led project. On a global level, honorable ministers, we respectfully request that ministers prioritize youth mental health and consider the recommendation proposed by young people and take them as you go through the UN high-level meeting on non-communicable diseases and mental health in September 2025. I really do not want to leave this podium today without recognizing my president, Her Excellency Dr. Samia Suluhu Hassan, and my minister on Jenista Muhagama, yes, for being instrumental in elevating this agenda in Tanzania. Asanteni sana. Honorable ministers, head of delegation, we, the young people, the Gen Z, we believe in the near future, we are going to make a happy generation with happy pictures. Thank you for listening to my presentation.
Thank you for your presentation. There are a lot of things that we knew, but we were again reminded of our responsibility as adults, because it's not every day that youngsters come and tell you that, you know what, I have a problem. Fix it. Fix it, because you don't want to recognize it, we recognize it, now you have to recognize it. So with these words, I will invite now that the ministerial panel discussion starts. We have Minister of Health Eswatini, Cabinet Secretary from Kenya, Honorable Minister from Tanzania, Honorable Minister from Malawi. Understand the moderator will be Dr. John Masiwe. So I suppose we should be moving there, right? Thank you.
Oh, thank you very much. Because you didn't mention that you were part of the panelists, so thank you for coming. I'm always part of the panel. Yeah, sure, anyway. Okay. Once again, thank you very much, honorable ministers and heads of delegation. So just to reiterate what Salome said, you know, mental health issues, once a subject that was surrounded by stigma and silence, is now recognized as a vital component of public health. She talked about the project that we are about to undertake, or we are undertaking as the EXA Health Community Secretariat. I'm happy to report that we are being supported by Commonwealth Secretariat. And we have Dr. Janet Mgamba, who has traveled all the way from London to be with us as we are stressing a point on mental health. Thank you very much, Dr. Mgamba. And at the same time, I want to thank the Office of the Director General, our Acting Director General. He sent out letters to permanent secretaries of the 9 EXA so that we should have information, because we want to have that framework she talked about. We are happy that some of the countries are responding very well. We do believe that the findings of that project will also present to you honorable ministers and heads of delegation. So thank you very much for your cooperation. So this afternoon, yes, it's a panel discussion on a mental health issue. You also agree with me that in most of our countries, the issue of suicide, it has taken, center stage. It's a talk of every day now. Yet these are things that can be, addressed. Like what Salome said, probably if we listen to the young ones and address their issues, we are likely to prevent some of these issues. So my first question this afternoon will go to all you honorable ministers and heads of delegations. So I will start with Eswatini. Could you please tell us about the mental health status in Eswatini? What are the current national priorities in addressing mental health conditions? And how are these reflected in the health policies of your country? Over to you, Honorable Minister. Thank you.
Dr. Shawangu, representing my minister, who's supposed to be the one participating. Unfortunately, their commitment at home is attending some of the issues at home. Thank you. Thank you for the opportunity. I'll just give a brief now, as the question now. I'll just give an overview that the mental health concern, I think it affects all of us, whether poor or rich, it affects everybody. The mental health condition in Eswatini impose an indirect burden to significant productivity via premature mortality, early labor force exit, and absenteeism and work at a lower capacity. You know that if you are affected mentally, your work productivity definitely will go down. So with us, as the whole suicide worldwide global health estimates reports of 2019 reported the total number of suicide at all ages in Eswatini was at, we are in a population of about 1.2 to 1.3 million. So at Eswatini 2009 report reported about 338 suicidal deaths, of which 27 were female and 310 were males. There is a huge discrepancy when it comes to the actual commitment of suicide. Furthermore, who reported that the African region has the highest suicidal rates in the world, estimated at 11.2 people per 100,000 population in 2019, and compared to the global average of 9 per 100,000 population that year. Eswatini was at 40.5 per 100,000 deaths population, making it the third leading country in suicidal rates globally and second leading in the country suicidal rate in Africa. So the country usually conducts surveys. So we conducted a step survey, which has recently concluded, 2024, which track two conditions in mental health. That's depression and actual suicide. That shows suicidal ideation were highest among women. So we discovered that most of the time, the women, they rate high on suicidal ideation, and then in men, which men are at 7.6%. And then you remember that I mentioned that the guys who are actually commit are the men, whereas they are the less. Now, when this percentage show a less side on the rating, and overall prevalence of 11.7% is both sexes. Similarly, depression in Eswatini for all participants was at 34.4%. This is the recent survey. Higher in female, again, is 37.6 than in male, who at 29.4, of which the discrepancy was that much year, although it still showed high on the female. The Kingdom of Eswatini, like many other countries, faces the burden of health challenges. There are insufficient qualified mental health professionals in the country. That's your psychiatrists. Currently, we have got one national health psychiatric, we call it psychiatric hospital, with one specialist, and the others, they're in the private sector. And then we have shortage of clinical psychologists, and then and the other supporting services. Mental health services are not fully decentralized currently. We are sort of they are centralized, that I mentioned, and then we have the outreach services that are being conducted. Stigma against mental health illness is still powerful, and more people attach negative stigma to mental illnesses as far as higher than other diseases or disabilities. People always think mental health is term of the worst case scenario. Most of the time you refer them as worst case scenario, will be thinking about those who are picking trash on the street, but I think the previous presenter has shown us that people that are having challenges even on their daily life. I was responding to the minister when he was asking me, how are you feeling? I say, I'm fine. So it's a huge challenge. Mental health does not get the same attention we gave mainly to the support that we are getting for HIV/AIDS, and it's still not mainstream into this Swatini society. And is mainstream into the educational system, is not forming part. There are less attention for funder support for mental health activities. So in Eswatini, the belief of witchcraft is still an issue, definitely like the rest of other African countries, that you may find that we still associate mental health with those and traditional treatments and healers. So according to the national health policy, the country is focusing issues on national health policy, which deal with NCDs and mental health prevention, and controlled services delivery will be implemented at all levels. So we have improved the components of the NCDs. We have included injuries and mental health, and then it will be headed by the same person, so that it can be offered the same level of attention. So the country is moving that route. So we are raising public and political awareness on those issues, and then there is advocacy for establishment of interministerial committees to stakeholder engagement and champion mental health agenda. Host forum with policy makers emphasize economic and social impact of mental health, and integrate mental health into social and developmental agenda and poverty alleviation strategy, and further integrate mental health into social and development agenda and poverty alleviation strategies, address policy and regulatory gaps, advocate for review of mental health order. Our mental health regulation, it was enacted in 1978. So we are in a process of reviewing that and mobilize domestic and external funding for mental health, and conceptualize and scale up mental health gap version 2. Currently we are at 1. This one, it focuses on the issue of expanding the package. You'll know that most, like I've mentioned, the mental health is sort of centralized. It has to be decentralized so we can enhance or get support when it coming to even utilization of digital platforms, so that we can reach the far end or difficult to reach areas. I think those are the areas that we are doing as a country currently. Thank you.
Thank you very much, from Eswatini. Mauritius on the same in terms of policy and governance.
Okay. Thank you. Well, we have to recognize that mental health is becoming younger and younger. Means youngsters are affected. Most of the youngsters say that, you know what, we're having school pressure, tuition pressure. Then I say, stop. I had it, so why didn't I become a problem? I personally think we have to recognize, and I suppose in Mauritius we recognize, is the new environment. Parents having less time for kids, social media is sort of being a drug, is being used as a drug. And when we talk about policies, our national priorities, one of the things that we have realized in Mauritius is it is not only limited to rural areas. All this problem leads to anxiety, panic attack, and policies have to be made and are already in place. We start from schools, primary schools, secondary school, university, tertiary, workplace. One thing recently would happen, which was an eye-opener for Mauritius, a child of 7 years was got with synthetic drug. 7 years. That is criminal. And when the psychologists and psychiatrists start talking to him, he started having panic attack. So we don't know, is it because of the drugs or lack of drugs? So this really makes you think that we need policy, all these policy about mental health should have a full weightage on what we call drug abuse. It should go through the Ministry of Education, Social Services, and everything to do also with parenting. I think parents should also be part of our national priority. They should be taught, you know what, you're a parent, behave, grow up. As the young person just made in a presentation, she was clearly telling us, you know what, adults grow up. It's high time you think of me. So thank you, madam, to make me grow up, at least mentally. So these are the priorities I think we should address in our country. And it should be reflected not only as a policy, what I say. I still maintain policies are paper-based. Let's have actions.
Correct.
What needs to be done? What are we doing? Are we doing enough? Not enough? Let's fix it. Thank you.
Thank you very much, Mauritius. United Republic of Tanzania.
First of all, through my Honorable Minister, I would like to respond to this question by pointing out that Tanzania, through its history, has made mental health services as one of the agenda. History of mental health in Tanzania dates back to 1896, after the establishment of the Lutindi Mental Hospital by the Lutheran Church. This is one of the oldest mental health institution in East Africa. And to date, there are 4 tertiary facilities with specialized mental health in the country, and 2 universities which can offer training to a level of master's and PhD degrees of mental health for doctors and other cadres as well. We have 28 hospitals that offer outpatient care and 11 that offer both OPD and IPD services with dedicated 10 beds or more for psychiatric patients, as well as 16 facilities that provide methadone-assisted therapies. There are 58 psychiatrists in total in country, which is equivalent to almost 1 million one psychiatrist to a million population, with a major workforce being that of social welfare officers, which accounts about 1,168, mental health nurses, 495, and mental health rehabilitation officers, which account for 181, and the professional with the at least number of staffs, and the professional with the least number of staffs is the clinical psychologist, and in the country we have only 35 of them. This shortage of staff necessitates use of task shifting approaches to curb for increased demand and mental health services. Now, according to STEPS survey, which was conducted in 2023, Tanzania has 20.3 overall prevalence of depressive episodes in the past 12 months, and this is among adults, males and females. But also there are around 13.3% of adult males and females who reported suicide ideas or attempts, with the 1 in 5 female reported to have such experiences. So if you go into country priority, you'll see that first Tanzania wants to curb high burden and increased demand for mental health services. As you have seen, the data has shown that we have a lot of challenges in terms of reaching the bigger population. Tanzania has put high priority on human resource for mental health, in which we have set priorities through presidential scholarship schemes, whereby doctors and even nurses receive specialized training on mental health services. In addition, Tanzania has also established the curriculum for high diploma on mental health and rehabilitation services, so that to allow proper task shifting to these mid-level cadres to increase workforce within a short period of time as part of transition towards better mental health programs. And third, use of integrated approaches at the primary healthcare level, in which all mental health services at the primary healthcare levels from health centers are provided under the mental health and NCD services after the orientation of workers. And in this case, I would like to report to you that at least 2,800 clinicians and 710 nurses have received such kind of trainings. This improved the access of mental health services closer to the community and improved the efficiency in utilization, or make human resources available at the PHC level. Right. And the fourth is alignment with human rights and the rule of law. In this case, we have enacted an act in 2008. And fifth, use of multi-sector approach to address mental health and psychosocial issues. Tanzania has the Joint National Mental Health and Psychosocial Services Action Plan, which was launched in 2025 for 2025 to 2029. But also, number 6, there is a prevention focusing on public health awareness and advocacy, and in this case, it covers throughout a wide range of media and etc. The Ministry of Health, in collaboration with WHO, has a national mental health dialogue in 2022 to raise the awareness. That was aiming to raise the awareness and mobilize public to engage in promotion and awareness of campaigns across the country. But lastly, there is an existence of indicators or targets which have been set in terms of addressing this challenge in service delivery and service utilization. I submit to you.
No, thank you very much, United Republic of Tanzania. And actually, you have isolated the best practices that we can learn from your countries. So let me proceed to Malawi before coming to Kenya. Could you please tell us about the mental health status in the country? and what are the current national priorities that we have in addressing mental health conditions?
Thank you, moderator. Let me recognize your excellencies, ministers of health, heads of delegations, ladies and gentlemen. Sitting here on behalf of the Minister of Health, Honorable Kumbize Kandodo Chiponda MP, who couldn't make it to the morning session, but she'll be able to join us later in the afternoon. Malawi, just like many other African countries, is also grappling with the issues of mental health disorders, so depression, anxiety. That is also rampant amongst our people. Usual causes, alcohol, substance abuse, but we should not ignore, natural disasters. They have also contributed. So the cyclones, the floods, gender-based violence. The government of health in 2011 established a unit that is responsible for mental health. Suffice to say that it handles both mental health and other non-communicable diseases. In recognition of mental health as a public health priority, you see that our documents, so the health sector strategic plan 1, 2, both of them contained mental health issues. The same is true for the one that we are implementing now. We have included the health benefit package in terms of mental health services. The minister again has a number of strategic documents that focus on mental health. So we have what we call the Malawi Quick Guide to Mental Health, which provides guidelines for mental health care. Also have the National Mental Health Policy, which ensures access to integrated quality mental health services, helps reduce, it also tackles issues of stigma in people with mental health issues. We also have what we call the mental health and psychosocial support guidelines. Again, this is to help practitioners on how to provide care. Just as it has been said by speakers before me, suicide is also a big issue, and the Ministry of Health has what we call the Suicide Prevention Implementation Framework. These are efforts that the government is making to try reduce or prevent prevent suicide. We also have the Mental Health Bill 2024. This bill seeks to repeal and replace the Mental Health Treatment Act, which was enacted in 1948. So there have been issues, emerging issues that need to be accommodated. We are also doing something in terms of access to care. Again, like other African countries, we do not have enough trained or specialized staff to provide care. The same is true, we don't have specialized institutions. So what has government done? We have integrated mental health services in the general service provision. So one can access mental health services starting at community level. At the health post, we have built capacity among our nurses, clinicians, and other health workers to be able to provide what we call psychological first aid. So you don't have to be a specialist in mental health care, really. We have also built capacity in our foot soldiers, the primary health care workers. As I said, at the village level, people should be able to provide some sort of psychological first aid. Our vision, tertiary level, to to establish mental health units and hospitals. We, as it is now, the government has one tertiary mental hospital, but we also have our colleagues from the Christian Health Association with whom we have a service level agreement. So people are able to access care from a non-government institution, and government pays for that. The ministry has reached out beyond health workers. We have been working with teachers, social workers, people from the police and the clergy, so reverends, fathers, bishops, in providing training to them to be able to provide the basic, which is psychological first aid. There was a passionate presentation on mental health issues by the lady from Tanzania. She touched on a lot of issues to do with youth and adolescents. The Minister of Health in Malawi established a mental health and psychosocial support task force in collaboration with the ministries of gender and community service to promote coordination of mental health issues among the youth and adolescent. Let me stop there for now, moderator. Thank you.
Now, so please tell us.
Thank you very much, Chair. Maybe just a disclaimer. I think over the years I've lived, I've had many statements. And one of the catchy one is that we are all mad. It only depends on the degree of madness. I don't know whether that is true or not. Having said that, maybe it's good. I don't know whether we defined what mental health is. Briefly, it is a state of well-being in which individuals recognize their abilities, can cope with normal stresses of life, work productively, and make meaningful contributions to their communities. We know that globally, the burden of mental health remains quite high. It's among the top 10 causes of disease burden. And there has been no reduction in prevalence since 1990, which means over the years, this burden is increasing. And you'll attest to it with the COVID-19. I think the mental health cases after COVID-19, during and after, actually shot up. And this is when the world got to be awakened by the levels of mental health burden in our countries. In Kenya, 42% of individuals who visit public health facilities actually exhibit symptoms of severe depression. And the burden of mental illness in Kenya generally is about 10.3%. We are talking of anxiety, severe depression, but also some behavioral changes. Actually, in one of the studies in one of remote regions in the country, the study showed that 50% of the population had reported at least one symptom of mental illness, and this is quite a bit serious. And so we have a presidential task force that was formed some time back to look into the mental issues in Kenya. And it reported that Kenya bears a significant burden of mental illness characterized by poor health outcome, psychosocial disabilities, premature mortality compounded by substantial gaps in access to care. And so arising out of this, we developed our Kenya Mental Health Policy 2015-2025, whose objective is basically to strengthen effective leadership and governance for mental health, ensure access to comprehensive, integrated, high-quality, preventive, promotive, curative, and rehabilitative mental health services, implement strategies for mental health promotion, mental disorder prevention, and substance use disorder prevention, but also strengthen the mental health systems. So what are we doing as a country in terms of implementation of this policy? One of the key issues is arising out of the policy. We did develop the Kenya Mental Health Action Plan 2021-2025 to operationalize the policy, and a review is underway to inform the development of the next action plan. Legislative reforms have also taken place. We had the Mental Health Amendment Act of 2022, which replaced an existing Act of 1989. And in this amendment, the High Court recently also reclassified suicide attempts as symptoms of mental illness rather than criminal acts. In the previous acts, suicide attempts had been considered as criminal acts. In terms of standards development, standards for the promotion, prevention, care, treatment, and rehabilitation of individuals with mental health, neurological, and substance use disorders have been developed in collaboration with our partners. Integration into the health systems, efforts to integrate mental health into the health information systems are also ongoing. Investment in mental health systems, investments focus on financing, leadership, products and technologies, research, human resources, service delivery, and infrastructure, supported by a 2021 mental health investment study that demonstrated double returns on investment. And I think I'll be talking about this later on when we'll be looking at resource mobilization for the same. Monitoring and evaluation frameworks are in place. We have a suicide prevention strategy, 2021-2025, that guides interventions, supported by a multi-sectoral committee overseeing its implementation. In terms of the governance structures, we have a dedicated unit at the Ministry of Health, a division of mental health unit that was formed to basically look at policy issues as far as mental health is concerned. So development of policies, guidelines, training and capacity building, both at the national and the county level. But we also have a mental health board that offers oversight. This is a multi-sectoral board that brings together experts, community representatives, NGO representatives to be able to offer guidance to the country. The other issue is training and awareness. We've developed quite a number of guidelines for training, especially primary healthcare facilities, but also community health promoters. Yesterday, we dwelt quite a bit on what services community health promoters can offer. And one of the key services is basically mental health. Not necessarily treating at that community level, but picking out those cases and referring them, both from the household and also the community. Some of the priority areas for us as a Ministry of Health is integrating mental health, and especially into the primary health care, so that these cases can be picked early and dealt with. Advocacy and awareness remains very, very important priority for us as a country. And lastly is issues to do with capacity development of the healthcare workers, because we realize that many countries have very few mental health workers. Like Kenya, we only have about 53 psychiatrists who cover 27 out of the 47 counties. When we talk of psychologists, the 47 counties, at least each one of them has one psychologist. I know that one is below, far much below the capacity that is needed to be able to address mental health issues in the countries.
So just one more thing that I needed to mention in terms of the facilities. We have 3 referral facilities, national referral facility for mental health. For the counties, we know that, like I've mentioned, 27 out of 47 counties at least have a psychiatrist. 14 county referral hospitals are able to admit, 14 out of 47, to admit patients and offer inpatient medical care. So basically that is it. I'm sure the other questions will be able to address the rest of the issues that are remaining here. Thank you.
Thank you very much, Kenya. Actually, honorable ministers and heads of delegations, I think you have covered most of the questions that I have. However, there are only 2 questions which I would like Kenya and Mauritius, and then I'll give all of you concluding, if you can give us concluding remarks. So, Kenya, we know that when it comes to financing mental health issues, it has been a challenge in most countries. What measures is your country considering taking to make sure that we have adequate funding for mental health issues?
Yeah, so thank you very much. In my previous discussion, I did mention that we did conduct a Kenya mental health investment case in 2022, which showed the economic burden of mental health at around 62.7 million Kenya shillings, which is about 570 million US dollars. So 62.7 billion economic burden of mental health in Kenya. That's quite a bit, which is about 0.6% of the GDP of the country, as per the study that was done in 2020. And so arising out of that, the government, through the Mental Health Board, did direct that the Ministry of Health receives a vote specifically dedicated to fund delivery of mental health services. And therefore, the Division of Mental Health that I did mention actually every year receives money. It has a specific vote dedicated to mental health. And that is a plus, which shows a highest political commitment that government is committed to ensuring that mental health receives the funding. We know, of course, this might not be adequate. And so we have other avenues which we are also getting support, including Ministry of Public Service has put in, collaborating with other ministries, but specifically with Ministry of Health, is doing something, and especially on issues of suicide prevention, helping the other ministries to develop their strategies for suicide prevention. But also we've seen other partners coming, NGOs, especially also the UN family. WHO and UNICEF have played a big role in supporting some of our mental health activities. We also have philanthropists who not necessarily give money, and family foundations that have come in to support, and especially in community mobilization, awareness, creation, and advocacy, but not necessarily giving money to the ministry. But of course, someone is paying for that, and so we consider that as a cost that someone else is also taking care of. But of course, because also of integration of mental health into other programs like TB, HIV, maternal and neonatal child health, they have their line budget, and therefore this integration has helped also to ensure that mental health, due to that integration with the funding from those programs, that mental health is also funded.
Thank you very much, Kenya. So, Mauritius, as a secretariat, we are envisioning of bringing in digital mental health platforms when it comes to improving mental health care delivery. But we felt we should find out from the member states. What role do you envision for technology such as telemedicine or the digital platforms I've just talked about when it comes to mental health delivery?
Thank you. If digital platform is the problem, we can use the same platform to help them. So this is what we are trying to do. All our schools, primary and secondary school, children have been given, I won't say iPad, but small laptops, which is paid by public funds with access to Wi-Fi. So that we can access directly to them, send them all kind of information, all kids, not through their parents, they could get, and through that we can access, we can control the access to things which is not important.
Right.
At the same time, this platform will be used to educate them, mentor them, and hold them. So this is very, very important. At the same time, one of the things, apart from technology, which we have used technology to help in the program called Drug Users Administrative Panel. When drug users don't want to come in person, they are being interviewed online, so that they don't feel the stigma of coming in a room and people keep on questioning, especially drug addicts. So this helps in our telemedicine and our mental platform. And everyone knows that through the central database that all government have on cell phone, we can access our youngsters, especially those. Now we know with AI, we know which sites you're accessing. We can use AI and push messages to those who are in some kind of mental distress. Thank you, sir.
Thank you very much, Mauritius. Actually, as I said, that's what the Secretary is envisioning of doing. So thank you very much for that. I know we are running short of time, but I give you 1 minute, Mauritius. Looking ahead, what is your vision for mental health care in your country over the next 5 to 10 years? And what key changes do you hope to see? You have 1 minute.
Well, in 1 minute, all I can say, I need to bring more professionals.
Excellent.
To help. And the second thing I should be doing is we should have private sector help us in terms of not only infrastructure, but sharing of information. And to continue with that, we should also accept that mental health is not a problem, is a condition.
Thank you very much.
So help everyone. Thank you.
Thank you very much, Mauritius. If I ask Eswatine the same question, looking ahead, what's your vision in the next 5 to 10 years as a country in terms of what you want to see the levels of mental health delivery in the country?
Okay, thank you. I think when on my presentation, I've just mentioned most of the things that we are looking up to and the things that we are doing already. So as a country, we realize that the issue of access is an issue. The issue, so it has to do with the decentralization of the service, accessibility of the service. And we are aware that the network coverage for the country, it has improved. Almost everybody has got access to a form of network now. And then the issue of telemedicine is the way that we want to go to improve access, more especially because the issue of specialists and the people who are relevant to offer the services, they are a challenge. And then we are also aware our policy is quite old, 1979. And then when it comes to issues of attending to the clients, it becomes an issue. To have a client, to have access to our facility, sometimes it has to involve police, you have to go to families and all those things. So it's an issue. The issue of policy now is key. And then the lack of other admission facilities when it comes to substance abuse and now. So we lack those facilities. It's an area that we are going to move into. So those are the key issues that as a country we think we should focus. And the other one that I mentioned before is issue of prioritization of injuries and mental health and incorporating to the NCDs.
Excellent.
So that when we declare, not yet, when maybe it's being declared as a NCDs are declared as an emergency, The mental health is also form part
Correct.
of that. Thank you, sir.
Thank you very much, Eswatine. Kenya, next 5 to 10 years, you also have a minute. What do you want to see in terms of mental health service delivery in Kenya?
Yes, sir, thank you very much. Like I did mention earlier that in the definition of mental health, issues productivity and contribution to society becomes very key. So we want to see a healthy population that is very productive, devoid of mental health. In the investment case study that was done in Kenya in 2022, it showed that for every $1 invested in mental health interventions, the results or outcomes or the benefits double, and that the same investment will give a productivity that will be seen 10 to 20 years later. So why not invest in mental health? And my call today also to EXA is to collaborate with the countries, particularly on issues regional mental health policy harmonization to address the unique challenges across the region, strengthen regional mental health research, through joint research proposal concepts, strengthen human resource capabilities through joint training and professional development programs, develop a robust regional mental health data collection and analysis framework, but also continue to enhance, like you have always done in other disease areas, enhance cross-border collaboration in mental health interventions.
Much. I know we have taken them on board, and as I said, as a secretariat, we are indeed, getting policies from the countries. We want to see the community-based mental health interventions, what's happening. So we do believe that what you have just said is what we are looking for. Let me ask United Republic of Tanzania, if you were to give one statement, what you want to see in the next 5 to 10 years, what would that statement be?
Yeah, you can't see people in need unless you have the services. So my call to the partner states for the EXA, start the services, whatever condition, you can use task shifting and skill delegation, and you'll see more clients. Over time, you build the capacity so that you have more professionals in the area. But on the way, you fix the plane as it is flying so that those available can give some basic services. So that is my call to member states. Secondly, stigma. Reduce stigmas. Because we see quite often, once you attend mental health, a person with the mental issues, when you attend them very adequately, they come back and they add it to the economy. They work very well. And thirdly, investment towards the services. Because you cannot have good services if you have not invested in that area. And this will cut across on training issues, making sure that we have the facilities, but making sure that you have overtime monitoring and supplies are available. Because unfortunately, medicines, when they are for the full-blown mental patient, they are very expensive. If we don't have mechanism to buy them, most of these will end in the streets and without treatment, and most of them we will add much more stigma so that they will end into a situation where you cannot rehabilitate them. I submit.
Thank you very much. I think the same question goes to Malawi. If in a minute, if you were to summarize next 10 years, what do you envision in terms of mental health service delivery in the country?
Thank you, moderator. We need to treat mental health as all other conditions. So we must, I repeat, we must integrate it into the services. So the primary level should have capacity to handle mental health issues. Secondary, just as we do with any other condition. How can we do that? We need to increase the numbers of staff that have knowledge. It's not by recruiting new ones. The ones we have on the ground, as I said, we need to train them. They need to understand. We need to improve mental health literacy. People should be aware that there is help elsewhere. They should not suffer in silence. And we need to learn how we handled other conditions, HIV/AIDS, for example. We had integrated it in almost all sectors. We need to do the same. This is an emerging issue, mental health. And finally, we need to improve domestic financing of our health sectors in member countries. I know because this is a mental health discussion, the temptation is say we should increase funding for mental health. We should look at the whole. Yeah? So once health financing or funding increases, we'll have enough for hypertension, mental illness, etc., etc. Thank you, moderator.
Thank you very much, Malawi. This marks the end of our panel discussion. Let me thank you once again, honorable ministers and heads of delegation.
Mr. Moderator, sorry to interject.
Just a minute. Sorry.
Yes, I have a very serious issue to raise.
Yeah. Actually, that's where I was coming, honorable minister. So, however, we may have one or two, comments from the audience. In the next 5 minutes, we may give, because the chair is also on the panel, so I think I'm taking over the chairmanship. So, honorable minister, you may proceed. Thank you.
Yeah, I'm sorry, I was ahead of you. And with due respect to the, I want to thank the panelists, and with due to the panelist from Kenya, I thought if we leave what he had said, that everyone is mad. My thinking comes to say that with the media they may think those participants, me inclusive, who attended 74th RSM Ministers Conference are mad. That's what I read through. Or everyone is mad. Now, I would really think with due respect that sentence should be expunged from the records of our proceedings in the panel. What I only agree with is that every one of us has a mental disorder of differently stress capacity. But say all of us are mad and we are sitting here in 77th Ministers Conference and we leave at that. So it's my humble request, sir.
Thank you very much, Honorable Minister. I think that has been taken note of. We understand. In case we have, yes, Commonwealth Secretary. So I've been told by the chair that should be probably one more comment, then we close.
So thank you very much, the moderator and honorable ministers and heads of delegation. I thought I should actually speak briefly about the Commonwealth Secretariat, and I would like, first of all, to just convey warm greetings from our dedicated Secretary General, whose tenure is actually ending in March, and we're expecting our new Secretary General to come from Ghana. We are really very excited. It's an opportunity for the African region to showcase the Commonwealth Secretariat work. We are committed to work with EXA region to realize the regional framework, which will be used as a model, not only for EXA, but also for other regions within the Commonwealth Secretariat. I just want to mention that we also have a small country technical support on revising mental health legislation. Many of our countries also have outdated mental health legislation. It's something of which we can also offer. So do reach to us if you also want to revise your mental health legislation to be up to date with international standards. And lastly, I would like to kindly request honorable ministers and heads of the delegation to pencil in their calendars on our upcoming Commonwealth Health Ministers meeting, which will be held on the 17th of May. You will be receiving details shortly, and our chair is actually the government of Lesotho. The meeting theme is on sustainable financing for an equitable Commonwealth, which is really indeed timely, especially during this particular global architecture. We also have a dedicated one session for sustainable funding for NCD and mental health, and we expect you, honorable ministers, you will continue these discussions which are happening today and come up with an agreeable, bold and visionary agenda for the NCD and mental health, one that prioritizes urgent strategies for the UN General Assembly in 2025. So we look forward to welcoming you in the upcoming meeting in Geneva, and also our partners, please do join us. Thank you very much.
Thank you very much, Commonwealth Secretariat. Chair, with your indulgence, I still have seen two hands. I think we shouldn't go beyond 13:30 hours. So maybe we may proceed. I've seen you have a minute, please.
Thank you, Mr. Chairman and moderator, honorable ministers. I just wanted to take us back to yesterday when all the honorable ministers sitting here mentioned how this is an opportunity. We are meeting at a time, this ministers' conference is happening at a very momentous time. Maybe God wanted us, to have this meeting at this time when each country is struggling with resources and how we are going to manage in the years to come. And the need to reset our mindsets and maybe rethink the way we organize our programs. So the Honorable Mauritius, head of delegation, talked about us needing to think outside the box. Moreover, in the last 2 days, we've been talking about a variety of programs which in essence are interrelated in some way. So I'm urging us to recognize the continuum of the public health issues that face our populations. For example, we talked about early childhood development, which includes building resilience among the young kids to be able to face the later years. We also talked about maternal and child health and the need to get that right so that child health becomes a reality. And then you move into adolescence, the need to take care of everything that comes before that so that adolescents are well set to face the challenges that come with adolescence. So I'm just urging us to not lose that thinking that we need to see how to optimize the resources that we have to be able to cross-fertilize these programs and to kind of break down some of the silos that we've been having so that you find the child health specialist doesn't talk to the maternal, health specialist, the adolescent health specialist doesn't talk to the early childhood development specialist. So I think as EXA, since we are the most highly affected region of all the public health problems we are talking about, I think we need, when we leave this meeting,
Yeah.
Mr. Moderator, Chair, and Your Excellencies, my name is Dr. Tembo Wanganivalu. I lead an organization called Action NCD International. I just want to bring two clarifications on what has been discussed from a scientific perspective. And for the latest one that everyone is mad, the WHO figure actually says that in a room, 1 in 4 individuals would have a mental health condition or issue. Maybe just to bring that across. The second one was actually by Maurice's in terms of wine drinking and the benefit of it to NCD. I know there's a U-shaped curve that scientists talked about that is still of a debate in terms of its cardiovascular benefits. But the other component to alcohol, which is relevant to the topic of youth mental health as well, is it is a cancer risk that is now equally, it's category 1 according to WHO and IAC, which means it is the same class as asbestos in terms of its cancer risk. So from a cancer perspective, alcohol is classified together with asbestos in terms of its carcinogenic effect. And for teenagers, it actually causes brain cell death. So every pint of alcohol that is actually consumed by teenagers, it causes brain cell death. So I just want to bring that clarification, but just to thank everyone with the notion of actually taking NCD to the next level in declaring NCD as an emergency in EXA. We together with EXA are ready to go with you hand in hand all the way to 2030, because the latest study in 2030 study is it is still possible for every developing country to achieve the SDG 3.4, and we can include mental health in that if the right investment is in place. We will be with you all that way and hope for the best as we take this to the next level. Thank you very much.
Thank you very much. So ladies and gentlemen, help me to congratulate the panelists for the job well done. Let's just clap for him. Thank you very much. You may take your seat. However, Chair, as you're proceeding, Uganda reminded me, because they were asked in the first presentation. So the question is, have they been passed? So I think maybe you can help us with those resolutions. Thank you, Chair.
So, thank you very much. I suppose we had a very good discussion, but time is always a problem. So, we are running out of time. We are having a time overrun of 30 minutes. In my office, when this happens, we have a penalty. I'm not going to say there is no lunch. There might be some issues with dinner. It's a joke. Just to tell you that we are 1:30, I'm going to wrap up in 1 minute what I take from the whole session so that everyone knows what we discuss. So this session was basically about NCD and mental health. We looked at the causes and how resources are being distributed. At the same time, one thing which has been touched is the behavioral factors of those who are having mental issue. Mental issue is also an NCD, right? So we have to understand that the burden of all this is on public finances. Economists say that we need development. As a health professional, we think of mental health and health in general, so we have to think about it. We have to also agree that one of the main problems of NCD is inactivity. Inactivity means we have no activity. Mental activity is happening all the time. We are sitting at the desk. We are having a glass of alcohol. Thank you, sir, for telling me that I can continue drinking. And I don't smoke, but I know smoking is also a danger. We have to have all of us are in this room, including all our ministers, that we have to take a political commitment, a firm commitment, so that NCD is declared as an emergency. We should go for that. And unless and until we declare NCD as an emergency, not much is going to happen. NCD and mental health, when we talk about it, we saw that kids are affected. They are our future. If we don't protect our future, then there is no future. With these words, I will plan to close this session with a thank you to everyone who contributed directly and indirectly and giving me the opportunity to chair this meeting. We'll break for lunch right now. It's 1:35, so I suppose we should be here around 2:30, if everyone is agreeable. So thank you, with a round of applause. Thank you. And before I let you go, I wanted to tell my young presenter, we want youngsters to be happy with or without the pictures.